to the fact that we had almost 60% of the participants in this trial were either Black or Hispanic. And then you can see the demographic breakdown there by insurance type and years in practice for physicians. And what we found in the unadjusted analysis is that overall, oncologists spent less time with their minority patients, being Black and Hispanic in this case, compared to their non-minority patients. And so unadjusted, that was a difference of about 5 minutes. And there was no difference in time spent, no statistically significant difference in time spent if there was progression at the time of the conversation, although, 2 minutes is a lot can be said in 2 minutes. When there was no progression, there was a significant difference in the time spent. And then we asked patients to rate overall how the quality of the conversations they had with their physicians, with their oncologists. And so what we said is sort of putting aside what you talked about, how well do you feel that your oncologist spoke to you about it? And overall, you can see there was no difference between minorities and non-minorities in how they rated that quality, with the scale being 1 to 10 and high quality being a 9 or a 10. About 70% rated their conversations as high quality. And yet, despite that, there was a difference in the time spent having these conversations, with oncologists spending less time with their minority patients. And when we adjust for patient insurance, education, income, progression status, and clustering within the sites, we essentially find that there's a 3-minute difference. So that oncologists spoke with their non-minority patients for about 17 minutes compared to 14 minutes with their minority patients. And one can argue that there's a lot that happens in 3 minutes of a conversation. If you think about having your own conversations, or even think about what silence might feel like for 3 minutes. And so questions that come up is really, what is the content of that discussion? What's happening, and how is it different between the minority patients and the non-minority patients? And so we're currently going through and encoding all of those audio recordings to be able to see what those differences are, with the hopes of, developing some sort of intervention or feedback process to give to those oncologists. And so we're finding that that minority patients are talking less, oncologists are asking them less questions, and minority patients are asking less questions of their oncologists. And so all of this comes to this question, right? Which is, how do we end up in this place where we seem to be creating a pattern of care that appears to be discriminatory? And, I think one of the potential examples here is the role of implicit bias. And so there's explicit versus implicit information processing. And there's system one, which is sort of the reflexive, there's a system one, which is a reflexive system for automatic thinking. And that's really fast. No effort, no motivation. That's the implicit system. And system two is the reflective system, which is more of the explicit bias. And, when we think of ourselves in these two systems, the conscious reasoning self that has beliefs and makes choices and decides what to think about, what to do. In other words, we tend to believe we're in complete control of our thoughts and actions. However, we know from research over the last few decades that suggests that this, in fact, is not the case, and that we're often reacting in an implicit way. And, the things that tend to bring out implicit bias are situations in which the clinicians are pressed for time. So, in that 20-minute visit, I have these things I need to get to. I have patients waiting for me. And in those moments, you tend to make snap decisions based off of your prior encounters, and it may not actually be based off of, and stereotypes, and may not actually be off of the person that you're experiencing in front of you. And when we look at implicit bias across the country, so there's something called the implicit association test, which one can take, and I highly suggest you do it if you're able. It's free, and it's called the implicit association test. And you go on this website, and they sort of track where people are across the country, and give this county level variation in implicit bias attitudes. And the darker the color, the more likely you are to have pro-white beliefs. over pro-Black or Hispanic beliefs. And you can take this implicit bias attitude test, not just for race and ethnicity, but also for things like obesity, religion. There are many other things that you can do. And in general, someone's considered having a strong preference for whites if their score is above a 0.6. Having a moderate preference, it's about 0.3 to 0.6. And then less than 3.3 would be a lower preference. And if you look across studies of implicit bias that's been done in healthcare professionals, this D score here is that range I just shared with you. And so for most studies that have been done, clinicians tend to fall within that moderate pro-white scale, preference towards white, which is pretty consistent with non-clinicians. And so how do we move towards health equity, which is, what I hope to leave you with, in that there are certainly ways that we can start improving this. And if we think again about specifically palliative care in the context of cancer care, this is a study we did in patients who were admitted to the hospital, cancer patients admitted to the hospital. And we followed those patients who received a palliative care consult and those patients who did not. And baseline, minority patients were less likely to be married. They had lower educational attainment. There were differences in cancer diagnoses, with particularly minority patients having higher rates of lung cancer and lower rates of gynecologic malignancies. And this table represents the outcomes of minority and non-minority patients receiving palliative care consultation. So this is at baseline prior to palliative care consultation, and the CMSAS is the Condensed Memorial Symptom Assessment Scale. And you see that across all symptoms, except for worry, minority patients were more likely to experience those symptoms. They were less likely to experience worry. They were less likely to be taking pain medications or report relief from pain medications. And similar to other literature, less likely to have advanced care planning documents or have talked about their wishes. This is after a palliative care consult. You can see that those differences pretty much all go away, with worry still being significant, and that minority patients still remains less worried. And so I think we know in cancer care specifically that supportive oncology palliative care is certainly specialized medical care that can help us move towards equity and really address many of the symptom outcomes that minority patients experience. And so in closing, I'd like to give you all some action items, which, again, is to consider taking the implicit association test at Project Implicit. And think about how you can be more deliberate in screening for social determinants of health if you're not doing that currently, and how you might be able to partner with those organizations who may help to be able to address some of those issues in your communities. I think we all need to make a concerted effort to really diversify the workforce. And I would offer that, one immediate thing everyone can do is really for those who either interact with patients in some way, to be intentional in those interactions. I'll give an example that I'm a thoracic oncologist, so I treat patients with lung cancer. And one of the things my team and I do is, if we're choosing a regimen for a patient and it's not the standard of care, or maybe it's not what we would normally do, is that we push each other to say, why did you choose this for this patient? What was it that made you feel that they couldn't tolerate cisplatin, for example, and really try to get to objective ways to make sure that we're providing equitable care for all. And so I'll leave you with a quote from the late Ruth Bader Ginsburg: "Real change, enduring change happens one step at a time." And I'd like to thank you for the opportunity to speak with you all and for your attention.
Thank you so much, Dr. Smith. I've already had many comments about how informative your presentation was and how they're taking notes, and can't wait to see more of your information. So I don't have any questions right now, but if anyone wants to add them to the Q&A function, or go ahead and raise their hand and we can go ahead and unmute you, please do so. And I'll just give it a few seconds. All right. Well, I don't see anything, but again, thank you so much, Dr. Smith, for being here today and sharing your expertise. And we're just thrilled to have you. So thank you. And with that, we'll go ahead and hand it off to Dr. Larry, who will introduce our next speaker.
Thank you, Dr. Smith, for that wonderful talk. And it's my great pleasure to introduce Otis Brawley, who's a good colleague and friend. He is the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins. I've known Otis for many years, and what I would like to do is at least give you a little bit of insight on him. He is the great-great-grandson of Edward McKnight Brawley, who was a Baptist minister and was born a free Negro in Charleston, South Carolina, who eventually became president of Selma University. His son, Otis's great uncle, was Benjamin Brawley, who became dean of Morehouse College. He has an incredible pedigree and legacy of people. Otis himself actually grew up in Detroit, and although his parents were not college educated, they really pushed the notion of college education. He went to a grade school, Catholic grade school. They enrolled him into a Jesuit high school, and he eventually went to University of Chicago as an undergraduate in medical school, did his residency at University Hospitals of Cleveland and Cleveland Clinic, and eventually did his fellowship at the National Cancer Institute. His Jesuit training really permeates his whole life. He has done incredibly well. He was a professor at Emory. He was the chief medical officer and scientific director and executive vice president of the American Cancer Society. He's won a number of awards, including the Distinguished Service Awards from the Department of Defense and the American Medical Association. He is also recently, and he's also a member of the National Academy of Medicine. He recently received the Martin Abelhoff Award for Excellence in Public Health of Cancer Control from the Maryland State Cancer Control Council. He's an extraordinary man. One of the things I did want to highlight, though, is a book that he wrote several years ago. And this Otis graced this association a few years ago and giving a talk shortly after this was published. It's entitled How We Do Harm. It's an incredibly thoughtful book, and I'm pushing it for you guys to try to get it to read. Today, one of the great joys I've had in my life is being able to sit down and break bread with Otis at different places around the world and have deep conversations about many things. One of the lessons that Otis told me one before, and I took notes on this, is that he told me that Jesuits don't teach people what to think. They teach you what you know, and what you believe. And particularly with the events of yesterday, I would love to be able to sit down and share with him a discussion about that and the implications of it. But I did want to read in his book here just the opening, and I think it'll set the stage for what Otis will talk about today, I believe, and certainly one of his thoughts. And this actually helps me with the events of yesterday. This is was from St. Ignatius of Loyola, who is the founder of the Jesuit teachings, and it's a prayer for generosity. He says, "Lord, teach me to be generous. Teach me to serve you as you deserve, to give and not to count the cost, to fight, not to heed the wounds, to toil and not to seek for rest, to labor and not to ask for reward, save that of knowing that I will do your will." So my friend, colleague, Otis, I wish I could give you a hug, man. Knock it out of the park. So one of the other talents of Otis is that he's one of the greatest minds in the history of the world. He's actually really good as a speaker if he takes himself off mute. So I would.
Thank you. Thank you so much. That was incredibly kind of you. I really appreciate what you just said. And I'm trying to share my screen now. That here. And but thank you so much. It's always a privilege to talk to this audience. I remember we had a meeting a couple of years ago in a church. Can you see the screen now, and is it on presentation mode?
Yes, we can.
Great, great, great. Thank you, Pat. Pat is one of the true gentlemen of oncology. And actually, this is a Forrest Gump moment for me with Pat's introduction and having to follow Cardi Smith is really difficult. Cardi is a little younger than me, but she's always taught me things. And so today I'm going to talk for a little bit about cancer control in the 21st century and how things are changing and how there are disparities in health, but those disparities are much different from what they were 20, 30, 40 years ago. First, my disclosures. I do some consulting for the government. I work for Hopkins. I serve on the boards of a couple of companies. Pat also showed you the book. I do still get royalties from it. It's used in a lot of ethics classes. So every fall and every spring of the year, I get a little check still. So I disclose that. What I want to talk about are trends in cancer death rate over the past 3 decades. Talk about our definition of race and how science is really starting to get scientific and understand the differences of what race is. Talk about other ways of categorizing populations, define disparities in the 21st century, and discuss some approaches to those disparities. First, let me start off by noting that this is the number of deaths and cause of death published by the CDC for the year 2019. And I use 2019 data because it was the last year in what I'll call normal time. I want to point out that coronavirus was number 3 in terms of causes of death in 2020 and got very, very close to number 2, which is cancer. There are almost 500,000 coronavirus infections in last year. Now, cardiovascular death rates have been declining faster than cancer death rates. Both have been going down, but cancer will become the most common cause of death in the US within the next 5 to 10 years. And it is already the leading cause of death for certain groups, for example, Black women, Hispanic women, and almost white women. This is, I'm an epidemiologist and a medical oncologist, so please pardon me for showing you graphs with data. In 1900, the age-adjusted death rate from cancer in the United States was 64 deaths for every 100,000 people in the population. It grew throughout the 20th century to 215. And since 1991, there has been a 29, soon to be announced 31% decline in overall mortality from cancer. This we consider progress. Studying this line, the rise over the 20th century, tells us a lot about how to accelerate that progress. This is the decline in mortality for Blacks, for whites, for Native Americans, for Hispanics, and Asian Pacific Islanders since 1991. You can see Blacks have had a greater decline, but they started with a higher rate. Whites have a disparity when compared to Native Americans, Hispanics, or Asians. Everyone's declining except Native Americans, which has a very, very small decline, but it's incredibly small. These are the 5 categories given to us by the Office of Management and Budget. Many people do not realize that the OMB in the White House is the official determinant of the racial categories that we use in collecting data in the United States. There are 2 ethnicities in the OMB classification, and they are Hispanic and non-Hispanic. Already you can see this is incredibly coarse and non-scientific. OMB actually says that these are sociopolitical and not biologic definitions. They are sociopolitical and not biologic. And this is a real problem because any of us who've ever filled out a federal grant from the NIH know that the NIH forms certainly consider them to be biologic. These categories are rejected by the anthropologic community as non-scientific, and race changes over time. One of my favorite examples of race changing over time is if you know someone who is from India, who was born prior to 1950 and came to the United States in 1950, over the last 70 years, they have been 3 different racial categories. And my all-time absolute favorite is by the OMB definition in 1970, Barack Obama was white. By the OMB definition in 1980, Barack Obama got to choose what race he wanted to be. There's a lot of discussion about diversity in clinical trials. Please keep in mind, a lot of that is political and not scientific. The NIH revitalization forces those questions on those papers that we fill out for the NIH. And please remember that while the NIH requires valid subset analysis, there's no such thing as a valid subset analysis if one has ever taken a clinical trials course. Now, that is not to say that clinical trials participation should not be encouraged. Indeed, it should be encouraged, especially since one of the things I'm going to talk about is one of the great problems is the number of minorities don't get good care, and NCI-sponsored clinical trials are a greater assurance of high quality care. I'll also add going to a doctor who participates in NCI clinical trials is a greater assurance of high quality care. We have studies to show, and this is actually a teaching point, I should put a slide here. We have studies to show that a doctor who puts 3% of his or her patients on NCI clinical trials takes better care of the other 97% than a medical oncologist or surgical oncologist who does not participate in clinical trials at all. Now, summing up this section, race is not a biological categorization, it's a socio-political construct. Area of geographic origin can be a little bit more biological. Ancestry.com and 23andMe have figured this out. Race is very broad. Area of geographic origin is more specific and scientific, although still quite broad, and admixture complicates this dramatically. When we start talking about areas of geographic origin, there are 109 known areas of geographic origin in Africa. Once anthropology starts studying Africa more, there will be even more. These are some of these areas of geographic origin. And when we talk about admixture, I should tell you, I am partly of the top 6 there, okay? When we talk about Europeans, there are 840 areas of geographic origin. Europe is more studied, more so by anthropology than anyone else. So when we talk about white or Caucasian, we're really talking about 840 different areas of geographic origin. By the way, when you analyze my genetics, I am from 8 European areas of geographic origin. Percentages do vary, but you can see the numerous areas of geographic origin. Now let's talk a little bit more about area of geographic origin and genetics and categorization to get you a little bit more comfortable with this concept. G6PD deficiency is well known. It's well known that there are certain G6PD genetics or deficiencies coded by certain types of genetics, different genetics actually, specific to the Mediterranean, certain areas of Africa, India, and the Middle East. The HLA-B1502 allele is common amongst people who live within 100 miles east or west of the Thai-Burmese border. Now this is an allele, 20%, by the way, of people who live within 100 miles of the Thai-Burmese border have this allele. If you give them Tegretol, they develop Stevens-Johnson syndrome. They get a fever, their mouth becomes raw, and their hands and feet start peeling. This is not 20% of people in Thailand. This is 20% of people in that one area, 100 miles east or west of the Burmese border. And it certainly is not 20% of people who are Asian. When you look at Asian people, you can actually tell the race is quite broad. It includes people from India and Pakistan, Korea, China, Japan, the Philippines. Very broad. So race is really too broad. The sickle cell mutation is also quite interesting observation. It has a high prevalence among people from sub-Saharan Africa, but it has a prevalence amongst people in Greece and southern Italy. By the way, it has no prevalence in the original peoples of South Africa. There is sickle cell in South Africa, but if you do tracing, you'll find that the people in South Africa with sickle cell have relatives from up north. The people from South Africa itself, or Southern Africa, I should say, the native people of Southern Africa do not have sickle cell. I just described for you, by the way, white people who do have sickle cell and Black people who don't. Yet we think of sickle cell as a Black disease in the United States. Sometimes we have these racial blinders on that we shouldn't have. As we go off into the future, the development in cancer, especially of drugs, will involve 30 to 50 person drugs tailored to a specific genetic and molecular marker. And we're going to use these 30 to 50 person trials to get our drugs developed. From this standpoint, we're going to have less emphasis on race, although we do need to study populations and figure out the prevalence of some of these markers in various populations. Now let's pivot and talk about what we do to try to lower cancer risk or risk of cancer death. Wise early detection, improvements in treatment, as well as risk reduction or prevention. I've stopped saying prevention and started saying risk reduction. These are the reasons why we've had a 29 to 31% decline in mortality since 1991. Use of these things. And by the way, I say wise early detection because there is unwise early detection. We can talk about that in our discussion section later. Cancer screening can be beneficial. It can also be harmful. It's often both. And we need to follow the good science. And Graham Kolditz at Washington University published this a few years ago. These are the causes of cancer and the percent of cancers caused by them. I want to note that smoking's at 33%, but I think of it as energy imbalance, the combination of being overweight or obese, having a bad diet, and lacking exercise, 30%. Think of it as a three-legged stool of energy imbalance, not obesity, but obesity, too many calories, and not enough exercise. 30% of all cancers. Now don't say 33 and 30, 63% of all cancers can be prevented because there are some overweight and obese smokers out there, but it is somewhere in the neighborhood of 45 to 50% of cancers can be prevented. Here's some of the other causes of cancer. I want to note alcohol is not thought of commonly too much as a cancer cause, but it is. Viruses is 5% in the United States. If we would go to Africa, it's 25%. We're talking hepatitis B, hepatitis C, HIV, human papillomavirus. Now, this is smoking in the United States since the mid-1950s, smoking over the last 65 years. Men, literally 55% of adult men smoked cigarettes in 1955. 35% of adult women smoked cigarettes in 1965. And here you can see the dramatic declines, which have led to some of those declines in cancer death starting in 1991. So you can get an idea of the lead time that smoking cessation and risk reduction takes a long lead time sometime to be showing up in our statistics. Tobacco is still the leading cause of cancer in the United States, although all the tobacco-related cancers are going downward in mortality except for bladder cancer. This is smoking by race and ethnicity. It is, I think, appropriate to use race and ethnicity in this respect because it refers to culture, the social, political categorization as opposed to a biologic categorization. By the way, this is not a misprint or a mistype. However, I did throw a curveball here. There is very little smoking in the southern United States among Native Americans, New Mexico, Arizona, very small amounts of smoking, but the Plains Indians or Plains Native Americans in North Dakota, South Dakota, Montana make up for it and smoke a great deal. This is the percent of smokers by education status. And this too is not a typo. There's probably a good psychology paper on what causes people who are driven to get a GED. Why are they driven to smoke in such high rates? But note, 4% of people with graduate degrees smoke, and it's now less than 7% of people with undergraduate degrees. This is a map of smoking in the United States. Now, I'm going to show you a number of maps, and I just want you to keep focusing on the southeastern United States. These southeastern United States, high prevalence of smoking in this last decade. And then we get to California and Utah, where smoking rates are very, very low. Pat Lair would point out that when I talk about smoking in California, I really need to be stressed. I'm talking about tobacco smoking in here in California. Cancers caused by infection overwhelmingly in the United States. This is hepatitis C and B and human papillomavirus. Human papillomavirus has really taken off in the last few years in head and neck cancer. The energy imbalance issue, again, and we have huge obesity problems. I'm going to show you a slide. This is an American problem, a uniquely American problem. And again, energy balance will be the leading cause of cancer in the next few years. This is the United States obesity from 1970 to 2010 compared to some of my other favorite countries. You can see everybody has a slight increase, but the United States is especially bad. It's especially bad for it's especially bad for non-Hispanic Black women. You can see the rise from the 1980s onward. This is obesity. 60% of Black women in the United States are obese, more so than any other group, but it is a problem for all folks. By the way, for children, we've gone from 4% of children being obese in 1970 to more than 20% today. Now that's an area where we can focus on for risk reduction, although keep in mind, risk reduction is going to affect our rates 15, 20, 30 years from now, not next year. Although smoking cessation clearly prevents cardiovascular disease 6 months after people stop smoking, by the way, you see a lowering of cardiovascular death. Breast cancer, the 2020 ACS numbers for breast cancer. There has been a 40% decline in age-adjusted female breast cancer from 1990 to 2016. About 40 to 50% of that decline is due to screening, by the way. The rest is due to treatment. We'll have a slide on that in a second. When we talk about Black-white disparities, there are 7 states in the United States where there's no longer a significant Black-white disparity. Most are the states that have the lowest death rate from cancer. And then there's West Virginia, where everybody has high death rates from breast cancer. This is mortality in the 1970s. And as we go to the right, you can see the mortality disparity for Blacks versus whites. There was no disparity in the 1970s. We learned how to screen and treat this disease, and the disparity starts. The disparity is greater today than it's ever been. This is the death rate for the other 3 races and ethnicities as defined by the OMB. Now, I said there was a 40% decline since 1990 in the United States as a whole. The United States went from being very heterogeneous in the 1970s and early 1980s, homogeneous. The United States was all the same, and now it's very heterogeneous. The purple states are the states that have had a 20 to 29% decline in mortality. The blue states are the states that have had a 44 to 51% decline in mortality. And so this is one of the punchlines of the talk. Health disparities, when I started doing it 30 years ago, was all about black and white. Today, health disparities is becoming more about Mississippi versus Massachusetts, the 20% versus the 51% decline. Health disparities is becoming much more about geography. It's rural urban. It's about outcomes having to do with education. It's about outcomes having to do with socioeconomic status. It still is outcomes having to do with race, but the disparate population is looking very different from what it looked like in the 1980s. Now, by the way, I noted that 40 to 50% of the decline was due to screening. The rest of the decline in breast cancer is due to treatment. CISNET studies show the following, and the politicians were always out there pushing, get a mammogram, get a mammogram. I wish they would read the CISNET studies. You see, failure to follow accepted screening guidelines accounts for about 9.5 to 11% of all breast cancer deaths. Failure of the diagnosed to receive appropriate treatment accounts to 21 to 27% of the breast cancer deaths. And hidden within this chart is we don't know how to prevent about 2/3 of breast cancer deaths that occur right now. Because some people actually think that every death is due. I say that because some people think every death is a failure either to get screened or a failure of the screen to be read appropriately. Truth be told, some of that does happen, but it is only about 10% of the 45,000 or so women who are going to die from breast cancer this year who die for that reason. But 21 to 27% of the women who die this year are going to die because of failure to receive appropriate treatment. And that can be not good surgery, not getting chemotherapy or getting a chemotherapy misdosed or getting it on a schedule that's inappropriate. It can be not getting radiation or getting the radiation therapy and it not being aimed. These can all be at the fault, some of it at the fault of the provider, some of it at the fault of the patient who can't keep appointments and so forth. But this is, I think, very important because logistically, if we want to save lives, if we want to save lives, more lives, we fix the logistics. This is not new science, this is logistics. Colon cancer. These are the numbers from the American Cancer Society for colon and rectal cancer. They combine colon and rectal cancer for deaths. There has been a halving of the death rate from colorectal cancer since 1980. I think this is an incredibly important, significant victory. The risk of an American dying of colorectal cancer today is half what it was in 1980. Now, that being said, inside the decline in colorectal cancer deaths that I'm celebrating, for some reason, there's a rise in the death rate of people who are in their 40s. We think it's probably related to the obesity epidemic and changes in diet, maybe the microbiome. But there's a rise among people in their 40s, but there's a decline among people of all ages. Screening is attributed to about 2/3 of the decline, by the way. This is the death rate decline from the 1970s onward, looking at women from colorectal cancer, blacks, whites, and the other three groups. You can see blacks and whites are coming closer and closer together here. This is the same for men. Again, in the 1970s, you did not have a black-white disparity. I want to note that up here as well, and you've already seen it in breast cancer. And here you can see Black and white men are getting closer and closer together. And here are the other three racial ethnic groups for Blacks and whites. This is a slide that was prepared by my staff at the American Cancer Society as we were arguing for the Affordable Care Act. This is just simply to show that insurance matters. I hate 5-year survival rates. They're so often misquoted. And perhaps that's the epidemiologist in me. This is the only time I'm going to show you a slide with 5-year survival rates. 60 months, that's 5 years. 0.7 is 70%, 0.9 is 90%. Stage 1 is in red, stage 2 is in blue. The dotted lines are people who are uninsured or who got Medicaid after diagnosis of colon cancer. And I just want to show that stage 1 uninsured are less likely to be alive at 5 years compared to stage 1 insured. Stage 2 uninsured, less likely to be alive at 5 years compared to stage 2 insured. Same is true, by the way, for stage 3, even stage 4. The insured are more likely to be alive longer. But I used this slide because in the United States of America, this is something we can really be proud of. You are more likely to be alive at 5 years if you have stage 2 colon cancer with insurance versus stage 1 colon cancer without insurance. You are better off being alive, and you're more likely to be alive at 5 years if you have the more advanced disease with insurance compared to the less advanced disease without insurance. Now, we talked about the 50% decline in mortality since 1980. Again, the United States used to be very homogeneous, and it got heterogeneous over time. And you can see 12 to 31% in purple, 55 to 63% in blue. And here, health disparities has become Louisiana versus Massachusetts, 12 versus 63% decline. Now, race and ethnicity, I would say socioeconomic status, does matter. And this is where we start getting into implementation research and what's going on in hospitals. And sometimes I worry that we, by pushing screening and other things, increase disparities, especially with lung cancer. More on that later. Kim Rhodes, wonderful paper. Minimum of 12 lymph nodes should be examined in an adequate colorectal cancer pathology specimen. NCCN says that, the American College of Pathology says that. Fact is, about half of all colorectal cancer patients have 12 or more lymph nodes examined. Or glass half empty, about half don't get 12. Hispanics, Blacks, and the poor have a much higher odds of receiving an inadequate pathologic assessment. Inadequate examination is often associated with the hospital where the care is received. Inadequate staging leads to some Blacks with true stage 3 disease being labeled stage 2, and some of the talk that colorectal cancer is more aggressive in Blacks. She literally found that in California, the average number of lymph nodes seen in Black patients was 6. The average number seen in whites was 18. There's a lot of Blacks who are stage 2 because there's 0 out of 6 lymph nodes with cancer, and a lot of whites who are stage 3 because they have 1 out of 18 or even 24 lymph nodes that has cancer. Now, it turns out all pathologists are not racist. The pathologists who do the fewer nodes have more patients to deal with in a day's time than the pathologists who do more nodes. Blacks in California tend to be treated in hospitals where pathologists generally have 5 or 6 cases to deal with per day. Whites tend to be treated in hospitals where the pathologists have 1 or 2 cases to deal with per day. It's a systemic racism argument. Causes of colorectal cancer are really, it's more systemic socioeconomic discrimination. Causes of colorectal cancer disparities are differences in the prevalence of screening, quality of screening, quality of diagnostics and pathology. And I emphasize quality because we always say get a mammogram or get a colonoscopy. We all say get a high quality mammogram or high quality colonoscopy. Differences in the proportion treated and differences in the quality of treatment. And there are differences by race, socioeconomic status, and region of residence. Let's go to lung cancer. These are the numbers for diagnosed and dying of lung cancer. About 154,000 deaths. This is lung cancer mortality by state. You can see the southern United States is not looking so good. This is where I point out when we talk about disparities, the death rate from all cancers in Kentucky is 195 deaths per 100,000 population. For all cancers in Utah, it's 125 per 100,000. One can actually say there's a Utah-Kentucky disparity here. The difference, by the way, is heavily influenced by lung cancer and breast cancer differences. Lung cancer screening came upon us in 2011 with a New England Journal of Medicine paper that involved 54,000 people treated at 33 of the finest hospitals in the world. They randomized 27,000 to spiral CT and 27,000 to a sham chest x-ray. And then they analyzed the data 10 years later to find a 20% reduction in relative risk of screening after 3 screens, by the way, 3 screens early on in that 10 years. New York Times, 20% reduction in risk of death with lung cancer screening. Everybody should get lung cancer screening if they qualified for lung cancer screening with the 30-pack-year history of smoking. To a true screener like me, in 33 of the finest hospitals in the United States, the death rate went down by 20%, but unpeeling the onion, for every 5.4 lives saved, there were 2 people who got sent to an intensive care unit due to an invasive procedure, and 1 person who ultimately died within 60 days after an invasive procedure. The study was done in 30 of the best hospitals. Results may differ when one does logo CT in facilities across the United States that are not one of the finest hospitals in the country. The benefit-risk ratio may vary. We at the ACS did a study looking at if everybody in the United States who smoked more than 30-pack years were to start getting screening and get it at the quality of those 30 hospitals, eventually when we got the steady state, there would be 8,000 to 10,000 less deaths per year. Remember 154,000 deaths per year right now. We decreased the number of deaths by 8,000 to 10,000, but we would literally kill I just lost my slide, I'm sorry. We'd kill 1,500 to 1,850 through diagnostic interventions, bronchoscopy, biopsy, and other things. The pro and the con for lung cancer screening. 6 respected organizations got together and said, if you qualify for this trial, and if you have good screening and treatment available, that's important, and you understand the risks and benefits, and you want screening, you should get screening. The important thing is you have access to good screening and treatment. Screening, diagnostics, and treatment, because it's the diagnostics that really hurt people here. I use this as an example because unnecessary care can sometimes interfere with an institution's abilities to provide necessary care. Right now, there are hospitals all across the country, and the Affordable Care Act has made this worse because the Affordable Care Act allows for people to get screened without paying out of pocket. What's happening right now is there are a bunch of, especially smaller hospitals, where a hospital administrator is diverting resources away from programs that are beneficial, maybe teaching young mothers how to care for their babies, maybe mammography screening, maybe cervical cancer screening. They're diverting resources away from that to buy expensive spiral CT machines, expensive software. Sometimes they splurge and actually buy a radiologist trained to read lung CT. Sometimes they get the radiologist who does broken bones and strokes and just says you have one more thing to do. These small hospitals, some of them don't even have pulmonologists and thoracic surgeons on campus who can do the diagnostics and treatment, but they find that they can balance the books a little bit by doing 3 or 4 spiral CTs per hour on their CT scanner. It's a real problem, and it's actually worsening disparities. Keep in mind what I talked about with the lymph node assessment in colorectal cancer. Sometimes hospitals start doing things and they do it, they overdo it. And by the way, state by state disparities are increasing with the Affordable Care Act. These in orange are the states that have not extended the Affordable Care Act to people age 18 to 65. And so let's go to the true cost, the true cost of healthcare, or true cost of American healthcare to me, just a simple cancer doc. I noted earlier that college-educated Americans have a much lower risk of cancer death compared to non-college educated. This is true among all races and ethnicities. It's estimated about 600,000 Americans will die from cancer this year. If all Americans had the risk of death of college-educated Americans, 22% or 132,000 would not die. This is 132,000 people who would not die if every American got everything from prevention to screening to diagnosis and treatment that a college-educated American gets. This doesn't require a new screening test. It doesn't require a new treatment. Indeed, I would challenge anyone to come up with a treatment, a breakthrough treatment, which could save 100,000 people from a cancer death. The logistics of getting everything that we know already exists, or at least everything that college-educated people get. Keep in mind, 7% of college-educated people still smoke. And that brings up the other issue. We can't do this next year. If Joe Biden and I had total control of everything, we couldn't save 132,000 lives next year, because this requires the long-term investment of risk reduction, the smoking cessation, the good diet and exercise, and those sorts of things. Those are long-term investments. The other thing to take away from this, of the 132,000 unnecessary lives lost, unnecessary deaths, 132,000 unnecessary deaths, of that number, 80,000 are white people. Ladies and gentlemen, I started my career in minority health more than 30 years ago, studying Black-white differences. David Satcher started calling it health disparities. Others are now starting to talk about health equity. And when I started over 30 years ago, I thought it was Black people who were not getting what they should be getting. Some people argued it was because of biology that we had these differences. I argued it was because Black people weren't getting what they should be getting, from prevention all the way through to treatment. Now I'm finding out that yes, that is true. A large proportion of Black people do not get what they should be getting, but the largest people to suffer from our pathetic healthcare system that cannot provide everybody with adequate care. The largest number of people harmed are white Americans. So the issue of health disparities and justice is not just a racial minority issue, and the Control of cancer should focus on disease prevention or risk reduction, mind you, as well as getting optimal basic care to all people, to include appropriate screening and appropriate treatment. Population disparities, by the way, always increase when there's scientific progress in medicine. You saw that when we developed the ability to screen and treat breast cancer or screen and treat colorectal cancer. The disparities in blacks and whites only started in the early 1980s. I'm often reminded there are no disparities in smallpox worldwide. When we have a preventative therapy, we frequently don't have these sorts of disparities. But we're going to see these disparities again with immunotherapy, some of the new precision medicines. I want to end with a slide. Sometimes we talk about equality, and this is equality, everybody gets the same thing. There's certain groups that may need a little bit more to get where we want to get, and certain groups that may not need anything or need a little bit less. So we need to think about targeted health disparities or solutions. This is my last slide. This is my home now. I live under the dome. I like to show this slide for the young medical students and some of the young doctors. This is the old Johns Hopkins Hospital. This is the hospital where Sir William Osler was the chair of medicine. And this was the hospital. The Jesus Christ statue is under the dome here. And the rooms were around the rotunda under the dome. And that's why Sir William Osler, when he used to see the patients in the morning, the young doctors and nurses there said Sir William Osler is rounding, and that's where the word rounds comes from to this day. And the young doctors who came to work with Sir William Osler, he would give them a room up in the tower, and they were residents of the tower. And that is why what postgraduate education for doctors is called residency to this day, from the old phrase, residents of the tower. I want to say thank you for listening to this talk. I really have enjoyed my visits to Indiana and Indiana University and the Indiana Cancer Council. And I still remember that beautiful church that I talked in, I think it was about 8 or 9 years ago. And with that, maybe we can have some questions.
Thank you so much, Dr. Brawley. We do have a couple comments and questions. First, just thanking for explaining that's risk reduction and not prevention, and clarifying that, especially from the patient advocate perspective. We do have a question about, why does small cell lung carcinoma have a poor prognosis?
Well, small cell lung carcinoma, or small cell carcinoma of any organ, generally has a poor prognosis. And you do see small cell in other organs other than lung. Small cell lung cancer is heavily related to smoking. It's poor prognosis for a couple of reasons. Number one, it grows very fast. Number two, the tumor doesn't cohese. We talk about tumor cohesion, the cells sticking together. The Otis cell carcinoma or small cell carcinoma, small blue cell carcinoma, those are all names for the same thing. The cells tend not to stick together and they can easily metastasize. So you've got something that's growing fast and something that can easily metastasize. Small cell is sensitive to our chemotherapies. However, even with immunotherapy, which it's also sensitive to, it tends to respond, and then all of it doesn't respond. It gets very small. We can't find any evidence that it's there anymore. And then it starts growing, and it grows resistant to the therapies that we first used.
Thank you so much. I think that's all the questions that we have. Actually, we just had one more come in. What are your thoughts on the newer USPSTF lung cancer screening guidelines?
Oh, I think that they're going to, the Preventive Services Task Force and by the way, they usually are very, very good. I like the task force guidelines. There have been times when some people would say I was the only person who thought the task force was correct. This guideline, I understand why they did it, but I also understand that they're going to create more confusion. Do we have 2 minutes to expand on this?
Sure, go ahead.
Okay, all right. The problem is, and this is the culture and race thing that I was talking about early in my talk. Perhaps it's best to think first about Europe. How people smoke, the culture of smoking, determines how much smoke is inhaled. Germans are very, the Germanic culture, they're very efficient in smoking cigarettes. So 30 pack years of smoke inhaled to a German is more smoke inhaled than 30 pack years of cigarettes inhaled by an Italian. The Italian culture allows people to smoke and hold the cigarette in their hands while they're talking, and the cigarette's just burning over here. The German culture doesn't allow for that. Now, instead of German Italian, let's say poor rich or rich poor. More wealthier people, white people in this country who smoke, are more in the Italian mode. Black people, cigarettes in Baltimore now cost $12 a pack. So they're very efficient in smoking those cigarettes. They smoke get as much smoke off of them as possible. So it turns out for blacks, maybe 25 pack years of cigarette smoking is the same as 30 pack years for whites. And the task force has now come up with race-based lung cancer screening. It's not based on biology. It's based on the number of pack years is different by socioeconomic status. Now, I happen to think they ought to come up with a guideline that says poor people in Appalachia should get the black screening guideline. That would rustle some feathers, but that's probably true.
Thank you so much, Dr. Brawley, especially for explaining that. That's particularly interesting, and I haven't heard that perspective before. I think that's we do have one more question. They keep rolling in right when I say that's all we have. You talked a bit about the rates of Native Americans that smoke and mentioned the great disparity between those in the plains and those in the Southwest. And then they were assuming the tobacco policy might be at the root of this disparity. Could you talk about that?
I don't know if it's tobacco policy or not. The smoking rates among people living on the tribal lands in New Mexico and Arizona are very low. I don't know if it's because of our cancer control efforts or because of culture. I just don't know the answer to that.
Thank you. And then we have another one. In obese patients that are having bariatric surgery, does that reduce their chances of getting cancer?
Really interesting point. We have very few studies to show that losing weight lowers risk of cancer. Keep in mind, the causes of cancer, smoking, for example, or obesity, take years to cause cancer. So if you remove those things, it takes years to see that the intervention actually lowered one's risk. The studies that we do have to show that surgery or weight loss in general decreases risk of cancer are some Scandinavian studies that looked at people who got bariatric surgery and started with BMIs of 45. People who were extremely obese who got bariatric surgery. The Scandinavian literature shows that. Now, unfortunately, people who go to Weight Watchers or Jenny Craig and lose weight in the United States, we don't have enough of them who lose weight and maintain that weight loss for a long enough period of time to answer the question that they just answered. The recidivism rate, the number of people who lose weight and then gain it back, is so high, the failure of weight loss. I can tell you that gaining weight increases risk of cancer. I cannot tell you losing weight once one has gained it really does affect cancer risk.
Thank you so much. I think that's all the time that we have. I know we do have a couple other questions that maybe we could follow up with you after, Dr. Brawley, if that would be okay.
Sure.
Thank you so much. Again, thoroughly enjoyed having you and having you back, and we appreciate you joining us, and all you do continue to inspire us. So thank you for joining us today.
Thank you. Thank you so much. I really appreciate being here. Let me just add one quick thing. The Affordable Care Act does not allow people in Georgia or a number of southern states who are 18 to 65 to have health care the way it does for many of the northeastern states that are blue. Somebody asked, was the ACA causing the health disparities? It's not allowing people to get to the ACA that's causing those disparities. And those are in certain states. They happen to be the red states politically for the most part.
Thank you for that distinction and insight. Appreciate it.
Mm-hmm.
All right, so it has been a great morning so far. We are just a hair behind schedule, but no problem at all. I do want to thank Dr. Box, Dr. Lee, Dr. Brawley, Dr. Smith for all your time and expertise today. We're now going to take a brief break and shorten it a bit. So if we could be back by 11:10, that would be fantastic. So take time to stretch, refocus. Thank you very much. See you soon. All right, everyone, it is 1:10, so we were going to go ahead and get started. I know how quickly those breaks go. So we have some great information to come, and I am happy to hand it off to Erica Pedroza for our next introduction.
Hi, Mary. Thank you for that. So for everyone who's come back from break, I'm Erica Pedroza. I'm with the Indiana Minority Health Coalition. I'm also a member of the Indiana Cancer Consortium board. So I'm very happy to be here, and the speakers have been absolutely fantastic. So it is my pleasure to welcome and introduce our next speaker, Rhonda Griffin, Senior Manager of Clinical Data and Quality at Goshen Center for Cancer Care and registered nurse of 37 years. Her career in healthcare began in Oklahoma, continued into Kentucky and Texas, and eventually landed her in Northern Indiana. While working as a discharge planner and swing bed coordinator in Texas, Rhonda started volunteering with the American Cancer Society. She focused on tobacco cessation efforts in school-age children and developed a comprehensive guide for healthier eating to reduce cancer risk. As a result of Rhonda's efforts with the American Cancer Society over the years, she has received recognition for her volunteer work at the district and state level. Rhonda has always had a heart for serving the underserved and providing access to essential healthcare screenings. She diligently works to improve the health of her communities by operating under the motto, where there is a will, there is a way. One of her most impactful projects to date has been working with numerous departments with Goshen Health to provide free colorectal cancer screenings to patients at average risk. Goshen Health has been proud to call Rhonda an exceptional colleague since 2000. She has participated in Cancer Committee and Goshen Hospital's accreditation process since 2003, while serving as the nursing manager for the majority of her time. In her current role as Senior Manager of Clinical Data and Quality, she passionately shares research and data to tell Goshen Center for Cancer Care's story of exceptional patient care and guides quality improvement efforts for the organization. Outside of the Center for Cancer Care, Rhonda has been married to an incredibly supportive husband, Alan Griffin, for 40 years. She's also blessed with 2 grown children. So, Rhonda, we're all dying to hear more about this important work that you do. So, Rhonda Griffin, everyone.
Thank you. I am absolutely delighted and humbled to be presenting at today's ICC virtual meeting. And maybe this title of the talk, Cancer Screening Engagement, Imagination and Humor, maybe that seems like an oxymoron to you, but I'm hoping today to convince you otherwise. So today, I genuinely do hope in your communities to help inspire creativity, to help you discover commitment and some new passion, and to stimulate the use of imagination and humor as you work to increase cancer screening and/or risk reduction activity in your own communities. So,
Hey, Rhonda, sorry, can I interrupt you for a second?
I'm muted, aren't I?
No, you're not muted, but
Oh.
we cannot see your slides. I just wanted to check and make sure.
Oh, okay. Thank you. Sorry, guys.
No problem. And we have your copy here as well, if you'd like us to share too.
Maybe that would be better because for some reason I'm being technically challenged.
No problem. Well, I can go ahead and share those.
Thank you, Mary. So Mary, could you go back one screen, please? One PowerPoint slide. All right, so move ahead to slide number 3. So as we are thinking about cancer screening and thinking about the challenges that come along, you may have had discussions if you're a provider with patients and trying to talk to them about the fact that they're of the age to be screened. And you may be talking to your patients about what is needed for, in today's talk, colorectal and breast cancer screening needs. And the average person may begin to think, what about my age? I don't have any symptoms. There are a lot of barriers to getting people to go through cancer screening. You also have instances where we have to talk about things like people's pooping habits. That is not especially comfortable, or people have heard about the screening tests. Women don't want to think about going somewhere and having to have a mammogram done. They've heard women talk about the pain of that. And then as individuals, if you happen to be a person of poverty, we've talked about several, or heard about from several of our speakers, if you're in poverty, or if you work in a factory or a service line job, you probably have little to no benefits. And if you're not at work, you don't get paid. So there are so many barriers to having people get cancer screening. Indiana happens to be a very agriculturally based state, and farms don't run 9 to 5. Or if you live in rural Indiana, there's a geographic barrier there. And as we've talked about, there are cultural beliefs and fears that prevent others from considering having screening done. So next slide, please. As we move ahead, the Indiana Cancer Consortium had a meeting back in February of 2017, the District 2 group. We would gather at the Harper Research Institute, and we had conversations about these exact concerns. And we needed to consider taking screening into the community, going to the people, overcoming some of these barriers that we have talked about. And as we were in the meeting, someone in the meeting, don't recall who, introduced the idea of flu fit testing. If you're not familiar, that is a concept of when flu shots are being given, that an individual can come in and have a fit test done, given to them, and be educated on how to use it so that you also get some screening activity done. American Cancer Society has done some excellent work, and you can go to the American Cancer Society website and get more detail. But it was in the midst of that meeting that I began to think, what could we do at Goshen Health, at Goshen Center for Cancer Care? What could our cancer committee do to move ahead with going into the community rather than being provider dependent, rather than focusing on individuals that especially do have insurance, that do have the ability to get to the doctor's office, to have those conversations. But how do we also get to the people that do not? Next slide, please. Which led to us at Goshen Health having a multi-year colorectal screening and prevention effort focused on individuals at average risk. It was initially a goal for our cancer committee in 2017 and lasted much longer. Next slide, please. We were able to go ahead and do a lot of research. We're a very data-driven organization. I am a data-driven individual. And so that led us to looking at our own individual facility. Next slide, please. In our facility, we, like many others across the nation, but in Indiana in particular, and looking at Elkhart County, diagnosed colorectal cancer at a much advanced stage rather than catching it early. And that was one of the reasons we chose to focus on colorectal cancer. I already mentioned that it was a goal for us, and we decided to use it both for screening and as a prevention activity. Those are required to have your accreditation. We ran into several barriers, and some of them were, how do we get to those people? And so we worked together to overcome, how do we get to these individuals as opposed to them coming to a provider office. And one of the biggest barriers we had to overcome is a very strong bias, and is prevalent across the United States, for using invasive tests known as that colonoscopy, and that is a gold standard was often language that I heard. And we realized you can't take colonoscopies easily out into the community. And so we wanted to go with a non-invasive test. So we did a lot of research about what are reliable non-invasive tests and what could we take to the community. Next slide, please. So we worked with our accountable care organization, and we worked with another business arm of our organization called Get Fit, Get Healthy. They are partners that have contracts throughout our primary care area, and they go into the factories and other organizations and do health fairs and wellness coaching and provide a great link to those sites for us. So we put our minds together, had excellent administrative support. We were able to identify organizations that would let us achieve some goals that we established. Next slide, please. Those goals very much were to go to the clients or the participants to identify healthcare providers that especially worked with underserved and or more poor populations, to make sure we used minimally invasive but very reliable testing. We wanted it to be free of cost. We did not want even the small cost of a FIT test to be a barrier for someone. When doing research, I identified that one of the failures for fit testing done in the community is often a lack of education provided to the participants. So we did a lot of work to educate the staff that would be sharing the fit test, as well as preparing materials, which I'll show you in a moment. We also wanted to make it possible for the participant to only have to collect the specimen and put it in the mail. We pre-addressed all of the mailing envelopes. We paid the postage, and we made it literally simple enough that an individual could collect the specimen, put it in the envelope, and as long as they had a mailbox, they were ready to go. We also had a big commitment wanting to connect every person or participant to a primary care physician. And we also wanted to ensure every person that participated received their results and had a connection to a primary care provider for further care, because FIT testing does require annual support, but this would get an introduction to and a education about why cancer screening and prevention activities are so important. Next slide, please. This is just simply a quick shot of the proposal that I prepared about what was going to be needed for us to do this project. And for those who count the pennies, we identified it would be about $6.84 per life to do this project. And after looking at some, if you will, return on investment, saving lives seemed invaluable to us, as did, we realized that if even just a few of these people came in and had colonoscopies, that our return on investment would be covered. The next slide, please. So this is a copy of the flyer that we prepared. It's very simple. We made sure that it indicated national guidelines. We wanted this to be evidence-based. That's important. We also wanted it to be simple enough that people would easily identify why cancer screening and prevention was important, as well as how to do the FIT test. Everything was bilingual, and we had good success getting these materials out. Next slide, please. So we kicked off the initial program in October of 2017, and we carried it through first quarter of 2018. And we were able, through our Get Fit, Get Healthy connection, to get into 26 different companies. We were able to work with 8 of our accountable care organization practices. We had 212 participants. Next slide, please. And this is the real success of our program. We were able to distribute 212 kits, and remarkably, we had a 64% return rate, which, if you do research and read about these efforts, many times people have a 3% to a 9% return rate. So to have a 64% return rate meant that that hard work had paid off. 11 of those who returned kits were found to have, if you will, abnormal results or positive results. And 8 of those 11 individuals chose to have a colonoscopy, and 100% of them, all 8, had multiple polyps removed. And that was an excellent outcome for that campaign. We still had some kits available, and our Get Fit, Get Healthy in 2018 and 19 carried on. Next slide, please. With their great help, and now the addition of real humor. So you've seen some creativity and some imagination to go in and use the research to go into your communities. Next slide, please. Next, we added humor. Yes, that is a Hershey kiss. And yes, that is a poop emoji that was stuck on the bottom of a Hershey kiss. And to the right of that image, there is what looks like a toilet bowl. It's a candy bowl that's attached to a toilet tank. And things like this were on the display, and they were disarming, and humor disarms and sometimes breaks down barriers and makes people more inclined to talk about things they just are not wanting to. But my favorite happens to be the blue superhero cape. And I don't know, I hope you can read it. It says Colon Cancer Crusader. And the staff would actually have some debate as to who was going to be the individual that would be the Colon Cancer Crusader of the day. So when you can spark some humor and excitement among staff, they're going to be more inclined to want to do this activity with participants, and that's a win-win. They also distributed 211 kits, as you can see there on the left. They had a couple of folks that had colonoscopies. One of those had polyps removed, and we appreciated very much their ongoing efforts. Next slide, please. The the next broader approach happened in 2019 and went into the first quarter of 2020. And that would be start a movement, share a stool. Next slide, please. So in Start a Movement, Share a Stool, there was a focus on the fact that about every 4 minutes, someone is diagnosed with colorectal cancer. And in that same 4 minutes, you could have a test that might save your life. Next slide, please. We took this broad marketing campaign through radio ads, print ads. You can read in local restaurants. You can see a picture of the stool that was there. We happen to live in the midst of a lot of Amish craftsmen, and there was an Amish craftsman in their area that was willing to make and paint and decorate these stools for us that went into all these areas. And the other thing that was a lot of fun was we had a stool bus. Yes, I like puns, and this was awesome. We were able to work with our durable medical equipment partner in the health system and wrap one of their delivery vans to be a stool bus. And then we went to where a lot of people are. We went into, had a tent set up at Goshen High School football games through a lot of the season. We took this to Notre Dame and tailgated at football games. And we also used our presence at Goshen First Fridays, which is a well-established and well-attended program. And people of all sorts of ages and background and race come to that event. Next slide, please. So at these events, we didn't give out the fit test, but we did drive the folks to a website called shareastool.com. At shareastool.com, they would take a health risk assessment, and if they were found to be at high risk, they were encouraged to be connected to a primary care provider. If they were outside of our primary service area, those individuals also were encouraged to contact their primary care provider. If they were at average risk, they were then, if they wanted, sent a fit test, and they could then return the fit test using the same mechanisms we had done with our prior programs. And so, next slide, please. The average risk participants, you know, hopefully the things that are at average risk, you're talking about people between the ages of 45 and 74. They did need to live close to Goshen. No colonoscopy in the last 10 years, no personal family history of colorectal cancer, no history of polyps or inflammatory bowel disease, and no active bleeding. Next slide, please. It takes a team, a creative team, and we had that. We had great support from administration. Our marketing department was remarkable with every phase of this campaign. Our cancer center colleagues, Get Fit, Get Healthy, our physicians in our gastroenterology practice and at our cancer center, as well as our lab team agreed to result the tests that were mailed into them. We had patient access. IT was incredibly important. We had to get those results of the lab tests done in our hospital lab back out to Get Fit, Get Healthy and their participants, and also back out to our accountable care organization. And the one that's not listed here but was invaluable was our Goshen Health Foundation, which did give us a grant to cover the cost so we could make this free of cost and take care of one major barrier for a lot of people. Next slide, please. So from October of 2019 into February of 2020, we were able to engage 420 participants. And we had 104 kits returned, which again is significantly above a national average. And we had one abnormal result. That individual did go on to have a colonoscopy and did have some influence in family members who were persuaded that maybe they could do a fit test, which could lead to having a colonoscopy done. Next slide, please. So at Goshen Health, the end of our mission statement is to improve the health of our communities through innovative, outstanding care and services, through exceptional people doing exceptional work. And next slide, please. That led to this multi-year colorectal cancer screening. So we started with a very targeted approach. The next year, we took it to an employer focused, again, going to the clients and trying to make it not scary to have colorectal cancer screening done, and did a broad marketing campaign after that. And next slide, please. And these were part of our campaign. We make sure your poop doesn't stink. And when it comes to number 2, we mean business. And so we found that using a team of individuals that were highly motivated and creative and humor, we were able to make an impact in our community with colorectal cancer. I would like to move ahead into an example of a breast cancer screening campaign that we did in 2020 that COVID had a significant impact on. Next slide, please. But just to show you a few slides from that program, that we at Goshen Health were perfecting the art of mammograms. And so we tried to make it less scary, to bring some insights to women, to encourage them to have mammograms. Next slide, please. We had some simple goals with the campaign. We wanted women to realize it was necessary to have those. We did want to increase mammograms in the months that were historically low, so March and April, and we wanted to increase awareness about our facility, the Goshen Health Women's Retreat Center. Next slide, please. The campaign again was focused primarily on women at average risk in Elkhart County. So that would be a target audience of about 40,000 women. Next slide, please. And then had a secondary target audience of women at considered to be at high risk. Next slide, please. The campaign strategies were to very much to reduce the fear associated with breast cancer screening, to focus on the ease of scheduling, to channel all traffic to a central hub, very similar to what we've done with the Share a Stool for colorectal cancer. And we wanted it to culminate in a really fun live campaign the end of April, but well, we know what happened. So moving on to the next slide, please. Again, we wanted to engage with facts, but in a non-scary approach. And you can see some of the strategies on the slide there. Next slide, please. And again, the marketing efforts went very broad. We did use some more humor, and we did wrap another bus, and it was mammograms or bust. Cancer screening doesn't have to be dull, and it doesn't have to be scary. And next slide, please. We also did some marketing through hair and nail salons, because almost every woman at some point winds up at a hair or a nail salon, and it's a great place to reach them. Next slide, please. There was a digital and a lot of PR activities that you can see, a very strong social media push for this campaign. Next slide, please. We did a live webinar through a grouping of events that we call Thrive. And so stay abreast of risk reduction and screening for breast cancer that happened October the 13th. Next slide, please. You can see Jody Barber there. She is one of our radiologists that reads a lot of our mammograms. And then next slide, also one of our breast surgeons, Dr. Fiona Denham, and a naturopathic physician that's with our program, Emily Moore. Next slide, please. All of the attendees at Thrive were able to participate in a raffle. So then there were some other activities that unfortunately we did not get to implement. So Mary, if you could go to the next slide, please. And then the next one. And the next. And then another slide, please, Mary. And so we had planned to culminate with the Breast Love Fest campaign. The end of April, it was going to be a red carpet event, a lot of hopes for that and a lot of disappointment that we were not able to go through. But again, I share these with you so that you can see the creativity and going to the people, taking campaigns to where people are so that they will be more engaged. Next slide, please, Mary. Next slide. And now, why it matters. Our other preceding speakers have made that clear. Next slide, please. That there are a lot of barriers that contribute to cancer health disparities in Indiana. These have already been stated. Next slide, please. That we want more women screened for breast cancer in the state of Indiana. And next slide, please. Next slide, please. From the National Colorectal Cancer Roundtable in the state, you can see Indiana is still behind for colorectal cancer screening in different age groups. And there is a goal of having 80% of our communities screened for colorectal cancer. And hopefully we're going to get there. Next slide, please. So there are a lot of experts coming and writing papers and showing us that while colonoscopy is the most prevalent method of colorectal cancer screening in the United States, it has not reduced our incidence nor the disease burden in the United States yet. So we have to be more aware of significantly decreasing colorectal cancer incidence and the disease-related outcomes. We are going to have to use more non-invasive testing. Stool fit test is probably the most readily available. However, it does require annual testing, and it is a challenge for primary care physicians to be able to keep up with that. There is Cologuard, which was mentioned earlier, a novel biomarker, and it holds a lot of promise. And hopefully, as we move ahead, the future is brighter for colorectal cancer screening. Next slide, please. If we are able to have colorectal screening get to be more readily available to at-risk individuals and not have significant disparities in access to screening, we will all benefit greatly. And such a future will also need to feature that non-invasive testing method that I previously mentioned. Next slide, please. So that one-size-fits-all approach to colorectal cancer screening has not and is not likely to result in increased screening uptake and the desired outcomes due to barriers stemming from behavioral, cultural, and socioeconomic causes. And so I hope that we will continue to engage and realize what we can do to go out to the communities with non-invasive testing. Next slide, please. One addition that's not yet in the recommendations from any of the national guidelines, but point number 3 on this slide I'd like to draw your attention to would be to use a personal risk assessment to better stratify patients that are appropriate for a colonoscopy or other more advanced screening techniques. And so there's a lot of research out there, and I did not have time to include it in this talk, but I think there's a lot of benefit. And we used a health risk assessment with the colorectal screening program when we did the broad marketing campaign. Next slide, please. COVID, unfortunately, has had a big impact on cancer screening and diagnosing of cancer. It is being diagnosed at later stages. And so getting into your communities, being as proactive as possible and going to the people. Our primary care providers are very busy individuals, and anything we can do so that screening doesn't just have to land on their shoulders will be of immense help. And last slide, please. I thank you for your time and attention today.
Thank you so much, Rhonda. I know you had a lot of great information there, and I'm so happy you got to squeeze it all in because it is really great and innovative work. we do have a few different questions that I do want to take a chance for you to answer. And so I think you might have touched on this one, later on, but I just wanted to give you a chance to add anything on how your team pivoted during the COVID-19 pandemic for the community for outreach and screening.
We modified the colorectal cancer, so it was strictly a web-based program. So through Facebook and some other social media things, people were still able to see that they could get to the website to schedule their mammograms, though for several months we didn't do any mammograms, and so that advertising had to be pulled down. But when we put it back up in, I believe it was early August, we did have a good response. A lot of people came back to have screenings done in August and September and October when that came back up. The colorectal screening, the Share a Stool movement, still has a Facebook and some other social media presence. And so primarily web-based, but we were still trying to have an impact.
Thanks, Rhonda. Another question, have you been able to get your GI group to be part of your campaign by offering free or discounted colonoscopies to those that are tested positive?
We have not, but we have been able to work with patient financial services or advocates as much as possible to make it affordable. We try very hard to do that.
Thank you. And then we do have this last one. First of all, loved the humor. But second of all, thoughts on unintentional effects of COVID-19 vaccines and tests that have had on regular health screenings.
There are several, I guess you would call them white papers or shorter papers that are out there. I have read several of them, and there is a suggestion that there are a lot of bottlenecks that are going to occur. And so I think, again, we're going to have to be creative and thoughtful and using health risk assessments, again, so we can help stratify populations, realizing there's no way that we can get all the people that need colorectal cancer screening in through a colonoscopy system. So going out, helping provide funding and doing programs similar to what we did with fit tests or other things that could help stratify individuals that need the testing priority is my only recommendation at this point.
Absolutely. Well, that's all the questions that I see. And I just want to say thank you again so much. I really do love this campaign. We've heard about in our Cancer Echo. So I'm so glad you could be here today. Thank you, Rhonda.
Thank you.
And so that it is time for our next session, and I'm going to go ahead and hand it over to Eric Richards.
Thanks so much, Mary. Good almost noon, everyone. My name's Eric Richards, and I'm the president and CEO of Cancer Support Community Central Indiana and a member of the ICC board. I have the absolute pleasure of introducing my colleague and friend, Eukarya Borden. Eukarya joined Cancer Support Community Headquarters in February of 2020. In her role as Senior Director, Health Equity and Clinical Services, she is responsible for ensuring that CSC Headquarters research, program, policy, and operations integrate relevant components of healthy equity, inclusion, and social determinants of health across all activities. She also works with the leadership of the Institute for Excellence in Psychosocial Care to inform the CSC affiliate network, including healthcare partners, on best practices in health equity. In addition to a focus on health equity, she's responsible for establishing new headquarters programming, as well as ensuring the highest standard of care for people impacted by a cancer diagnosis. Prior to joining CSC, Eukarya worked for nearly 20 years in direct practice with adults living with chronic illness. 12 of those years included patients in acute inpatient and outpatient hospital oncology settings. She holds a clinical social work license in Pennsylvania, where she earned her master's degree in social work from Temple University. She earned her bachelor's degree in psychology from the University of Maryland, Baltimore County. She's a past president of the Association of Oncology Social Work and is recognized as an AOSW Fellow. Following Eucharia's presentation, she'll facilitate a panel discussion with 4 Indiana survivors, including Lisa Hayes, Bruce DeArc, Krista Wilson, and Richard Mann. And just a little bit about our panelists here. Lisa Hayes, my friend Lisa Hayes, she's the director of Women's Health Services at Gennesaret Free Clinic, and she began working with Gennesaret in 2008, 2 months after completing treatment for breast cancer. At the time of her cancer diagnosis in 2007, she was uninsured and working in a temporary job. That circumstance has given her a special empathy for the medically underserved and a strong commitment to breast health education and advocacy. Along with the personal breast cancer experience she brings to her position, Lisa has over 20 years of experience serving low-income populations as a lawyer, manager, and health educator in developing community relationships. Lisa was instrumental in establishing the Red Alliance, a nonprofit organization with the mission to eliminate late-stage diagnoses and breast cancer deaths for Black women in Indianapolis, and was named as its executive director in 2017. She also volunteers her time and expertise with the IU Simon Cancer Center's Health Equity Advisory Committee, Indiana Cancer Consortium, Women of Influence, and Indiana Minority Health Partners. Bruce DeArc is a stage 4 colon cancer survivor and thriver. He was diagnosed in 2018 and is currently going through treatment for metastatic spread, but still living life daily. Bruce is a 20-year veteran of the Jeffersonville Fire Department in Jeffersonville, Indiana. He is currently the deputy chief of the department. Bruce is married to his wife, Janet, and they have 2 daughters, ages 18 and 23, Tori and Kayla, respectively. Krista Wilson is a stage 2 breast cancer survivor. She was diagnosed in March 2020 during the start of the pandemic and underwent a right mastectomy and radiation therapy. Krista is a registered nurse who currently works for a pharmaceutical company. She is active in many community organizations and 2 specific to breast cancer. Krista is married to her husband, Anthony, and they have 1 son, Chris, who is 20 years old. And last but not least, Richard Mann is currently an Indianapolis firefighter and paramedic. He received his master's in counseling and mental health. In addition, he served in the military through the Air Force and the Army. He has been married to his wife for 41 years and has 3 children and 6 grandchildren. Please join me in welcoming Eucharia.
Thank you so much. I am so excited to be here with all of you today. I want to try to get to the panel as quickly as possible, but for the next 10 to 15 minutes, I'm just going to talk to you about a few things regarding survivors and healthcare disparities as we prepare for that discussion. Next slide, please. Not going to spend a lot of time here. This is just telling you what we're talking about. What is cancer survivorship and what challenges do survivors face? Next slide, please. So as we think about how we define survivorship, and certainly I'm going to give the panel an opportunity to tell us what survivorship means to each of them, I came across this definition from the National Coalition for Cancer Survivorship. As you can imagine, there are many definitions of survivorship, but what I like about this is that, you're living with, through, and beyond a cancer diagnosis. And I included the year here for a reason. What this tells you is that cancer survivorship is not new, whether it was called survivorship or not. In fact, prior to this diagnosis, cancer survivorship was defined in a lot more clinical terms. It had to do with who was surviving, literally meaning who was living for a certain number of years past a cancer diagnosis. And while that's part of what survivorship is, that's certainly not all of what survivorship is. Survivorship also entails this part about the living part of it. And what does it mean to really live with a cancer diagnosis or through it, or beyond it, or a combination of all of these things. And I think that even in 1986, they were getting at the varied nature of what cancer survivorship looks like and who cancer survivors are. Next slide, please. So there's a lot here. These are some of the challenges that you can find if you do a search for the things that survivors face. Now, some of these you can do on a search, or as you heard Eric say, I've spent a lot of time in hospitals, a lot of time with cancer survivors, and there's so much more. We could break this out into several slides, as a matter of fact. And the challenges that survivors face are as varied as survivors themselves. We could bucket these out in a lot of different ways, but the main point is that survivorship touches every aspect of someone's life. It permeates every part of your being, your family's life, those around you, whether we're talking about emotional distress or what it looks like for nutrition and what that means, what it means for work, returning to work, not having work or interrupted work, what that means for treatment side effects, fear of recurrence. There's a lot of challenges that survivors face. But even with this, there's still a subset of survivors that maybe in more recent years have gotten attention. And that's the part that I want to talk to you about today. Next slide, please. So this probably doesn't come as a surprise to anyone, but I include it because it's important. The challenges and the concerns that are present at the time of a cancer diagnosis can absolutely be exacerbated in treatment, beyond treatment. I always used to talk to patients about the fact that cancer happens in a life that was already being lived. And so that means that if there were marital issues, there's a potential for those things to be exacerbated. If there are financial issues, there's a possibility that those financial issues may not improve, or they may change and become something that no one planned for. If there are, competing priorities, raising children, but also caring for an elderly parent, and now you yourself are the person who needs help or who needs support, or you're moving through that process, there's so much that gets impacted in your life when you are living with cancer or living in survivorship from a cancer diagnosis. So let's go to the next slide. Now, I just glossed over material that we could talk about for a couple of days. And that's because I know that you've already been talking about that today, but also because we want to get to that next layer. The idea that there are health disparities is not something new, and it's more than an idea. Cancer health disparities are real. And depending on who you are, where you live, what community you're a part of, then you have a different experience with health disparities than maybe another cancer survivor. The reality is that cancer really does affect everyone, all of the populations in the United States, but certain groups bear a disproportionate burden of cancer. Next slide, please. So on this slide, there's a few things. These are some of the risk factors that are associated with disparities, and you'll see that they are varied as well, and they stem from genetic and biological factors to healthcare access, socioeconomic factors, chemical and physical exposures, diet, physical inactivity. There's more that we could add here, but that layer that's there has to do with things like poverty, discrimination, and psychosocial barriers. And for some of us, these are things that we have always known, maybe because it's an experience that we were living, or perhaps it's because we have worked with people who are poor or who've been discriminated against, or who really do have what feel like insurmountable barriers to overcome in their lives. And I think that we can talk about it a little bit more freely now. I'm one of those people who's always talked about these things because they've always been important. But I think following the events of 2020 and into 2021, these are certainly topics that you're hearing more about. And we wanted to make sure that we gave attention to this today. We can now say things like institutional and individual racism without people rolling their eyes. Maybe some still do, but not in the same way to say, oh, here we go with that again. I think there's new light that's been shed to help everyone understand that depending on the community that you're a part of, then you understand the impact of these, and or you may be just now learning about the impact of these. And so these are some of the most reinforcing variables that lead to that health inequity. If we don't all have the same access, for example, then we don't have the same opportunities. That means we also don't have the same opportunities for health or to be healthy or to live healthy lives, even in survivorship. As I talked about how a cancer diagnosis or thriving after a cancer diagnosis can exacerbate the issues that are already there, it certainly includes factors like poverty, for example. And then you layer on even more the impact of COVID-19 and how that has disrupted cancer care. So if you were already part of one of those groups that was living with a disproportionate burden of cancer, and then COVID-19 is layered on top of that, and that in and of itself has affected everyone across the world. But now there are these added factors that are amplifying some of those pre-existing health disparities. And we see this in things like varying access to telemedicine, implicit bias on a number of levels. Implicit bias is something that I spend a lot of time talking about, teaching my colleagues about, and certainly it comes into play when we talk about the impact of COVID-19. Some things haven't been so implicit either. And let's go to the next slide. So when we think about some of those challenges that you saw initially, let's think about what some of those added challenges are for groups that bear a disproportionate burden of cancer. We're talking about things like resource scarcity. And this is something that we're hearing a lot more about, as you've all seen the numbers of people who are unemployed go into the double-digit millions, something unprecedented in many of our lives. Food insecurities, food deserts, and even pharmacy deserts. You know, there's so much time that's spent blaming sometimes these groups that bear a disproportionate burden instead of understanding what some of those barriers are. And we need to acknowledge that this is another area where access is an issue. We've talked about COVID-19. We've talked about the higher unemployment rates, but also thinking about the underassessment of needs, especially for cancer survivors. You know, when you're in active treatment, one of the things that patients have said to me so often is that they're nervous because I won't be here all the time now. I'm done with my treatment. And as much as I didn't invite this into my life, I've gotten used to having everybody here around me. Now what? And so when those survivors come back in for follow-up appointments, if they can make it back in for follow-up appointments, are we doing a good enough job as providers assessing truly the needs of people in various groups? But it's also recognizing that there are power differentials between providers and patients, and that the idea of shared decision-making varies depending on who you're asking and whether or not they truly feel that it's shared. There are microaggressions that people face every day, not just if you're a person of color, but even if you're part of any other marginalized group. This happens. We all do this. But even varying health insurance coverage, as there are fluctuations in employment rather. So sometimes people don't make it back in. You know, how are we addressing those things? How are we supporting and reaching out to people who really need us? And so I want to go to the next slide and just talk for a moment about an example which brings all of these things together. So I met a patient named Beatrice. And Beatrice had finished treatment for breast cancer. She came in for follow-up and seemingly was doing well. She looked great. She had put some weight back on and was dressed very well and said something that I wasn't anticipating hearing in that moment. As we talked about how she had been absent for a little bit, and I said, "It's great to see you. You know, how are things going?" She just sat there. And after a pause, she said, I need to tell you something. And it's something that I didn't talk about while I was in treatment because frankly, I was really embarrassed. But it hasn't improved and I just need to tell someone. That's when she told me that she had become homeless and that this is something that had persisted for a while. None of us knew this. She talked about things like, I'm getting an income from public assistance, but it's not enough to secure permanent housing. Food insecurity was an issue before, but it's a really bad issue now. I eat what I can when I can, but I don't have a way to get food warm. When I go to food banks, they give you cans. Well, I don't have a way to open those cans or to do anything with them to keep that food warm. So I'm using burners, when I can, so that I can get a little bit of kerosene. We talked about issues like access to running water, transportation to appointments, needed supplies like lymphedema supplies. Did she have a family? Yes, but they were also unaware of what she was facing. You see, the medical team, when she met with them, they would say things like, where have you been? What's been going on? We've missed you. You haven't been here. And on the surface, those things are not inherently bad things to say, but they didn't exactly ask a question that she felt she could answer. They didn't ask a question where she felt she wouldn't be judged. She didn't feel that anyone would understand her. And so through this disclosure, we were able to work together to start to address some of these issues. But sometimes when we lump cancer survivors together and we talk about cancer survivorship as though it is one experience that everyone is having, we actually do a disservice because we miss the people who really need us to see them, to truly see them and see their experience and acknowledge their experience. So let's go to the next slide. So what's next? What's immediately next here is we're going to talk to a panel, but what's next in care is making sure that as providers, we are asking the tough questions and having those tough conversations. It's making sure that we are really meeting people where they are and helping them to understand that we really are here no matter what you have to say. It means going to appointments and finding someone, even if it's not your physician, because it isn't always, finding someone that you can talk to say, hey, I really need something. Because we want to partner to make sure that our cancer survivors are getting all of what you need to truly thrive. And with that, you can go to the next slide. That's my overview about what happens when we think about the varied experience of cancer survivorship and how that meets the healthcare disparities that are existing and in some cases persisting. Now we're going to move on to our panel. And I'd actually like to invite those of you who are on the panel to come on to your camera. And I'm just going to call on you. I have a few questions, but I'd actually like you to introduce yourself first, if we could do that. Lisa, why don't we start with you? I'd just like everyone to please share a little bit about yourself, just, who you are, when you were diagnosed, what type of diagnosis, or what your experience is. Lisa?
Good afternoon, everyone. As you've heard, I'm Lisa. You heard Eric share my brief bio. I will further share that I was diagnosed with triple negative breast cancer in 2007. And so it was somewhat shocking to me because I was, at least at that time, one of those people that thought most people that are diagnosed with breast cancer have a family history. I did not have a family history. I was very healthy. I had never been in the hospital other than to have my 3 children, stayed pretty active. So it was surprising to me. But not only surprising, it immediately felt devastating because, as you heard at the time, I was in between jobs and did not have health insurance, as well as my husband. We were both working temporary jobs, and so neither one of us had health insurance. And so for me to find a lump and then to ultimately be diagnosed with breast cancer at that point was scary, but only for a moment, which I won't go into now. It might come up later in terms of communications, but and resources. But that was a scary moment. But I had a lumpectomy followed by 8 rounds of chemotherapy and 36 radiation treatments. So I went through all that, and I got to the end of that and went to see my oncologist, and she says, "Okay, great, you're done." And I was kind of like, where's the medicine? I mean, during my treatment, I'd heard about women taking things like tamoxifen or Remedex. And so I was waiting for that prescription, and she says, "Oh no, there's nothing for triple negative breast cancer. I have nothing to give you." So that kind of ignited my interest in research, particularly triple negative research, and in the disparity that Black women face as it relates to triple negative breast cancer. So I'll stop there.
Thank you, Lisa. And Bruce, why don't you tell us a little bit about yourself?
How are you?
Good, thank
Hope
you.
everyone can hear me okay. We are in a car traveling to Nashville to pick up some of my scans. So
We can hear you.
So I was diagnosed in March of 2018. I was 49 years old. Of course, as everyone, you never expect to hear those words. I'd experienced some discomfort in my abdomen, was losing weight. I was extremely tired, blaming it on the winter blues. And I had some extreme pain in my abdomen, so went to the doctor thinking possibly appendicitis. And after CT scans, we found 2 large baseball-sized tumors, one in my colon, one in my abdomen, along with smaller tumors in my abdominal lining. So that that hit me pretty hard. You know, it's never been in my family. I've never had any type of cancer in colon. I couldn't have guessed that in a million guesses. Since that point, I've done a lot of research. As we all know, we have to be our own advocate for sure. Doctors, oncologists do as much as they can, but I think we have to sometimes step up and do our own advocacy on our bodies. And that's actually why I'm doing this now, to go get a scan so I can meet with the surgeon about one of my tumors. So going above and beyond what oncologists sometimes want you to do, but I think you have to do that. So, but since then, you know, I had a major CRC surgery, removed the tumors in July of 18 after 6 rounds of chemo, had the HIPEC procedure as well. Come out of the surgery cancer-free. I was finished up 6 more rounds of chemo at the end of 18 and was going into 19 thinking, you know, we're moving forward, we're going on. So I made it about 6 months, I guess, before another spot had popped up. And I believe at that time it was in my liver area. And that was a spot we had watched from the beginning. So it wasn't something that was surprising. So started some more chemo, figured out that wasn't doing the trick. So we moved on to, at the end of 19, going to MD Anderson looking for some trials. We were able to go in December of that year, and then 2020 hit, and it kind of changed the outlook of stuff. I was fortunate to get in this. I missed a trial there. I was able to do the same medication locally in Louisville, which is just south of Jeffersonville. So we're at the southernmost point of Indiana, so we're on the good side of the river, what we like to say. So we did that part of the trial. It was not working. COVID hit, pandemic hit, and there was a lot of restrictions to get to MD Anderson. And so we decided to, along with our oncologist, to stay local at that time, just for a few months to try to get through. We went on some Starvaga, we did some other stuff just to try to get through, and then ended up going to Sarah Cannon, Tennessee Oncology. Worked through a couple of trials there that worked in some areas. One worked in some areas and not the other. The other one did the complete opposite. So at this point, we're back to Louisville, University of Louisville. I'm currently on LawnServe as a bridge until we find the next trial. And we're going to work on that. I just started 2 weeks ago. So feeling great. Hoping that this scan will help me get some issues solved in my liver area. And we'll go from there.
Great. Thank you so much. Krista?
Hi, thank you for having me. My name is Krista Wilson. I was diagnosed, well, I feel like I really knew the last day in March, but it was officially diagnosed on April 1st, so on April Fool's Day in 2019. So right during the pandemic, the beginning of the pandemic, I was diagnosed with stage 2 invasive lobular carcinoma in my right breast, and I am PR positive and HER2 negative. I did have a right mastectomy and no chemo, but I did have radiation therapy. And so, you know, I just forgot the question.
That's okay. I was just asking, no worries. I was just asking each of you just briefly to tell us a little bit about yourself and your cancer journey. That's all. You were right on target.
Okay.
Did you want to share anything else now, or would you like to stop there?
That's good.
Okay, sounds good. Thank you. Richard, how about you? Richard, you're still, oh, there you go.
All right. My name is Richard Mann, and I'm a young 60-year-old with 3 children, as I mentioned in my bio, and a lovely wife and 6 grandkids. And that's my medicine for the cancer. Last year, I was fortunate enough to be in Key West diving. And after a dive, I felt something on my neck, and it was a lump. And so I had out once I came back from this little miniature vacation, and had it checked out, and it was diagnosed with thyroid cancer. And then during the PET scan that I had taken, I found out I had another tumor in my throat. So bear with me too. Sometimes it's kind of hard to talk. Still a little bit sore. I had the surgery, the first one with a neck resection. Was I think end of June of last year, and then I opted to go with robotics for the throat, and they removed the tumor there, and they checked everything out, and said all margins were good, and so I go in for checkups every 3 months, and so far so good. And initial plan was to do chemo and radiation, but they held off on that since the margins all look good right now. So that's pretty much it in a nutshell.
Great. Thank you, everybody, so much for sharing and for being here to share with us. Over the next 15 minutes, I'm going to be asking a series of questions just to learn a little bit more about your experiences. And Lisa, I'm going to jump back over to you to ask you, what does survivorship mean to you, and whether or not there's been any impact from COVID-19, which could be anything, could be physical, mental, emotional, but what does survivorship mean to you, and how, if, because maybe not, but has there been any impact from COVID-19 on your survivorship?
All right. So again, as you heard in my bio, I do a lot of advocacy work now, both as a volunteer and as a paid employee. But I'm often asked, how do you figure out how long you're a survivor? When do you start counting? And, I think it's up to each person. But for me personally, I consider myself a survivor as of the day I was diagnosed. I was diagnosed on May the 1st, but I know the cancer was there prior to that. So as far as I was concerned, until May 1st, I had already been surviving and have continued to survive. So that's how I count it. But I also look at survivorship. I've kind of adopted this this line that survivorship is a lifestyle, and that each day that I survive, each day that I'm living, is turning into a different lifestyle for me, because I want to continue to be a survivor and to be a thriver. So certainly that my diagnosis and treatment, as well as the work I've been doing since then, has changed some of the ways I take care of myself, and some of the things that I encourage my family and friends and others, within my circle about their own health. So, but I think I'm no different than any other survivor of cancer, or whether, you know, any other traumatic experience, that you have a newfound sense about your mortality and what you're going to do with the rest of your life. And so I know for many, including me, it was a life-changing experience, because I went from one career to a totally sort of a totally different career, but it's one that I'm passionate about. And I have come to believe that my cancer experience was just preparing me for what my next career step was already going to be, that was ordained by God, that I needed to be the one to do this. And so because of my own experience, I think that I'm able to serve as an advocate and assist women in a much different way than I had pre-cancer. So, so in answer to the question about COVID-19, I didn't feel any personal impact from that. So I put on my advocate hat, but from an advocate side, there were definitely an impact, because pre-COVID, I was very often going with patients to their consultations, to their treatments, to providing emotional, sometimes physical support for patients. And so that changed dramatically with COVID-19. And what I was often hearing from patients at that time is they just felt like they were so isolated, or they really lost their, in a way they were independent because they had to be, but it was forced on them. So they didn't like that. And so I also had to, as an advocate, try to adapt to some different ways of providing support, and trying to work with treatment providers to be receptive to that. So, instead of being present in that exam room at that appointment, I was doing FaceTime or asking if it was okay if the patient could record the conversation, so that if she wanted to go back and listen, or to have me listen to it, that might be an option. Did a whole lot more text messaging with the women that I serve, because that was a way just to keep connected, and let them know that anytime day or night, that if they needed somebody, that was a way to reach out to me.
Thank you so much, Lisa. I really like that. Survivorship is a lifestyle, because it is a lifestyle, and there is that continuum that's there. And I can only imagine that the people that you serve are so benefited by your support. So thank you so much for that.
Thank you.
Bruce, what about you? What does survivorship mean to you? Was there any impact from COVID?
COVID, actually, I came out okay with that. Luckily, I was in the middle of taking a trial at that time, so I was able to do a lot of telemed visits, and University of Louisville was still open, so I could do visits. It was different, of course. It did. I think it opened up the general public's eyes of what maybe cancer patients deal with daily. On staying safe. With the mask, with social distancing, and when you're going through treatments, of course, for sure. And so to that point, I think some people may have learned from that. I think also, as she stated, cancer is a life. It does change your lifestyle for sure, and it's not a death sentence to me. It's a life sentence. It's a live life sentence. So right. I think it opens your eyes to do more. To do more to help anyone you can. I've become a big advocate. Prior to the diagnosis, I was in my role in my job was to part safety in our department, and the safety is also cancer awareness. Cancer is becoming a lot more aware in the fire service over the past 10 years. It's always been there. There's 12 cancers that you're at a higher risk getting as a firefighter, and colon is one of them. And unfortunately, I am the pioneer of our department of having it while I'm still in active duty. So it's helped open a lot of eyes in our department, in our area in general, to get colonoscopy. There's a lot of people who got them that may not have got them after my diagnosis, and found polyps and was able to take care of that. Some younger people were able to have issues that found polyps. And I think the age moved to 45 last year, which I was able to be a part of in the state of Indiana, helped tremendously, but we still have more work to do. We all know it's a younger disease now, and we need to move towards, I think, an earlier age, but it's a work in progress, I think. And in the fire service alone, I think it needs to be a lot younger, and because of that. So, COVID again, I think it, in my eyes, I have stage 4. So do I think every day what's going to happen tomorrow? No, I don't. I don't think like that. I think of, I wake up, I'm blessed every day to be here. I can be an advocate I work a lot directly with the Colon Cancer Project out of Louisville. Mm-hmm. And my wife is actually on the board there since she got designated on there after I was diagnosed. But they do a lot of great things, and they work through me and we talk with fire departments about early screenings, about how to keep clean, how to do different things. So I'm anxious for that to get started back with this with the pandemic easing up some. So I'm anxious to get back in person doing that stuff, because I think that's part of my calling now, to do that. And so it sounds weird, but I enjoy talking about my story, because if it can help one person, to go get checked, that's what it's about. And I will continue to do that. And it's never going to get me. It's my mind. I really believe it's 90% in your mind. I really believe that. And I've always been positive. I have strong faith, which has gotten me through. Of course, we have bad days. Everyone has bad days. And just to say a little thing about our caregivers, I don't know what we would do without them. It's my wife we got married in November of 2017. So I promised her a world of adventure, never like this, for sure. So
and you've delivered, huh?
Yes, for sure. I said, I didn't know we was going to spend the first year of our marriage in the hospital, but we did. So yeah, but she's always been my rock, for sure. So, but our caregivers what they go through is amazing themselves. So
absolutely. Bruce, thank you so much for sharing that. And it sounds like it's having quite an impact on you too. And, great. Continue telling that story. Yeah, you're right. It is something to manage. It's not a death sentence. And it is something where our thoughts affect our behaviors. You're absolutely right about that. So thank you. And Krista, what about you?
So survivorship to me is really, it's not a straight path. I think it's more of a winding road, because each day you kind of wake up maybe with you're on a different path that day. Maybe you felt something, so you have a little bit of fear of, is that cancer related? Is the cancer coming back? Is that a new lump? Or, just some days you just have joy. You may have a little bit more anxiety as well. And then just physical challenges, at least for me personally, because of the medication that I take every day, causes, some physical pain. So just trying to work through that, and just having, just the will to keep going. But even for me, even at the beginning, I was really looking for a lot of information. I wanted information about my disease. I wanted to know about treatment, and just what to expect each path of the way. And I really wasn't finding what I wanted, or at least for people that look like me. So I did find a lot of things on YouTube. And so for me, people, before me, both Lisa and Bruce had talked about advocacy, and that's where I was from the beginning. So I was, trying to find information for myself. But then when I couldn't find what I wanted, I was like, well, I got to create it. So I did start a YouTube channel, just kind of chronological, trying to tell my story along the way, so that the next person that was brown, that looked like me, that was trying to find, someone who had their diagnosis, because even just finding people that had my diagnosis was rare, because I think 10% of the population that's diagnosed has invasive lobular carcinoma. So it was hard to find both those two things, someone that was brown and someone that had my diagnosis. So I did those things, but COVID, I think, impacted me a lot, because from the beginning, I felt like I was alone. From the initial diagnosis, I just remember, and I'm sorry, I just remember just not being able to walk. Like I couldn't, my legs were so weak. And just all throughout that, I just feel like I was just always by myself. You know, I'd have my husband on my on my phone in appointments, but it's just not the same. So I think you know, just going through this with during the times of the pandemic was just very difficult. And I think sometimes it becomes even more difficult because your friends and family that want to assist you in any kind of way, whether that's just to come to sit with you or to bring you food or flowers or anything, they can't do that. So you know, what I did, I just try to keep going, and I try to be there. I felt like I tried to be for them what they were trying to be for me. And in part of that, I think I don't know. It's just COVID, I think, just put another layer of difficulty on top of an already difficult diagnosis. So I think survivorship is, of course, different for everyone, and we all have our own unique paths that we have to go through, but it's about living and sharing and what can I be for others. So I have been lucky in that I've been able to connect with support groups, but even that's not the same, because it's not the same not being able to touch someone or be face to face and have that hug when you need it, and you know, just that good cry. So I do think it's posed some challenges, but it's also, we've been creative in ways to connect.
Thank you so much, Krista, for your honesty and the emotion. And yes, it has been, it's a lot. It continues to be a lot in many ways. And I think, you know, one thing that you said reminded me of something that Bruce said, which is really thinking about, you know, the awesomeness of the support that you get from caregivers and care partners and, you know, all of them around you. But what happens when that's not possible? And I think that the world, you know, pivoted the best that it could, all of us in it. But at the same time, you're right, it is very different. But what I love about what I'm hearing from you is that you continue to keep moving forward and to try and adapt and to continue to seek sources of support for yourself, which is incredibly important, and also to try to continue offer support to others, which is also very important. So thank you so much for sharing with us. And Richard, what does survivorship mean to you? And has COVID had any impact on your windy path, as Krista calls it?
Yeah, I like that, the winding road, hills and valleys.
Yeah.
Well, shortly after my diagnosis with cancer, November, I ended up getting the virus and tried fighting it off at home, and then finally went in and went into the ER and was admitted, and my lungs were full. You know, I've had pneumonia before, bronchitis, but nothing like this COVID with a thick mucus, and I was bioxygen 80% and not knowing whether they're going to try to intubate me. And I was against that. I'm glad I was. But I was in there for about a week. They put me on remdesivir. They did a plasma convalescent transfusion, and that seemed to work out quite a bit. And it helped out with my bones too, the remdesivir, because I think it's for arthritis, and I've had both hips replaced, knees, and kind of falling apart there. But when I was in that room with COVID, and you know, not having family members there, the way I made it through that was I knew the Lord was there, and I saw I wasn't alone, ever alone. And that got me through it. And then shortly after that week, I was able to go home, and they kind of rushed you out of it because they needed the room for, you know, incoming COVID patients. And so I was on monitoring system where they monitor you every 4 hours, your vital signs, and my family was a big part, you know, being nurses, you know, blessed into the nursing career field. My wife was spectacular, taking care of me there. I felt psychologically at home, and I think it gave me the strength, you know, to rebound from the cancer and COVID. But, you know, mainly because of the Lord being next to my side, I felt fortunate. You know, I don't fear death. And I think that's just my way of looking at it. And I told my wife if I didn't make it on any of those situations that I said, it's a win-win, you know. She's a win-win. I said, I'm happy to be here with you right now, but if I go, I know where I'm going. That's pretty much it.
Thank you, Richard. How are you feeling now? May I ask how are you feeling now?
Today's not a good day. I'm kind of tired, and I think it's because of you know, I ride Harleys, and so I need nice weather. And for some reason it snowed. So, and I'm going to deal with it. I know in a couple of days it'll be 80 degrees again.
Okay.
Throat's a little sore, or, you know, just tired, but overall happy.
Thank you so much for sharing your story with us. And, you know, one of the things that stands out for me as I'm listening to you is we're talking about many things all at once, but the idea of what it means to cope. And as you are living in this space that we call survivorship, it really is about coping, coping with a variety of things, whether that's physical or mental or, you know, social or even spiritual. And I love that you brought that up too, because so many of you have talked about the ways in which you have either been supported, continue to receive support, or you're giving support, or maybe all of those at the same time. And so you've all brought in various elements of what that support looks like in survivorship, which is great. And I just want to throw a last question out there because we're coming up at the end of our time. And the question is this, you know, as you've been on, whether your road was more narrow or more windy, you know, just as you have been in this space called survivorship, is there anything that you feel either your community around you or healthcare providers could have done differently to improve, you know, life after diagnosis and treatment? And if so, what resources would you have recommended? Lisa, why don't we start with you? You're still on mute.
All right. Sorry. I said I was going to try to make this succinct. What I've been thinking about was actually something raised by the speaker, the first speaker this morning, talking about communications. Her focus was on, you know, patient-provider communications, but I think this can apply to whether you're, you know, a caregiver, a provider, an advocate, someone that's, you know, providing services. I just think it's very key to, as you're working with patients, to not only look at the patient, but see the patient wherever they are on that path of survivorship. And two quick stories that has really enlightened me. Like I said before, I do a lot of inpatient visits, patient visits with their providers. And so I see a lot of different ways that providers interact, some good and some not so good. But there was one particular provider that came into the room, spoke, looked at the patient, but then turned his attention immediately to his electronic device and pretty much talked to her while he was buried in the electronic device. And she was very put off by that. And in comparison, there was another encounter where the doctor walked in, sat down, got right at eye level and said, "How are you today? I don't want to talk about your cancer right now. I want to talk about you. Tell me about you and your family." And that opened the door to, in her particular instance, something very revealing that changed the whole course of her treatment. But what it said to me is that it's very important not to just look at a person, but to actually see and feel what they are experiencing at that moment. And it might be different than what it was, you know, the last time you saw them, or it's going to be different from the next time you saw them, because like as Krista was saying, at different points along that path, different things are happening. And so, on one day where somebody might not be having a day of anxiety, that next day they may. And so we can't just assume that where we see them in one moment is how they're feeling, or in order to really address their needs. And I think it goes back to the story that you talked about with the patient, that her treatment team knew nothing about her homelessness, or perhaps if somebody within that realm or another caregiver or advocate would have really taken a little more time to establish that relationship and really find out what's going on in someone's life, not to pry, but to offer assistance. So I guess that would be my takeaway for today.
Thank you, Lisa. Bruce, is there anything that the community around you or healthcare providers could have done, or maybe did do well, to improve quality of life after your diagnosis?
I think everyone tries in the healthcare industry itself. I think they're so overwhelmed with patients, new cases daily. I know just in my story, my original oncologist, we really liked the oncologist. However, you would get maybe 3 to 5 minutes with them, when they're talking, because they're so busy. And I think that that's a factor, that when they come in, your appointment is say 1 o'clock, they get there at 1:55 and they're gone by 2, and you're sitting the rest of the time just thinking. And I think sometimes it helps to have them come in and sit down and discuss what you have going on and what's going on in your life. And for me, that was always a factor for me. That was one of the factors why we changed oncologists at the time. And again, she was a great oncologist, other than just not enough time. And we've worked into more of a team atmosphere at University of Louisville, and kind of like that better. And I actually have had my best relationship with my surgeon, and that did, of course, he was inside of me for quite a while, 14 hours. So I think we got to know each other more than I wanted to. And so, but he's a realist. And so we met with him this week. And again, I'm hoping this pans out the way we want it to. But, I think they do the best they can. I really do. And I think the community wise, I mean, they surrounded me like I've always been the person to give, never been the person to ask for help. And it was very tough for me in the beginning, to ask for, and people sometimes don't know how to talk to people with cancer. They think you have the plague, or you have, you have cancer, you have stage 4, well, you're dead. They don't want to talk to you. So I shut negative people out of my life. And I learned from that. And I learned to always, how are you doing? I'm blessed. It's not, I'm never going to be perfect. I don't put on a front. I am what my wife sees me at my worst times and my best time. And I think it's a learning experience every day, no matter how long you've had it. I treat this as a chronic disease. It's going to be with me for the rest of my life. Well, I don't know if I'll ever hear the term NED, and that's fine. That's I've learned to accept that, and I will handle whatever's thrown at me. But I just continue to live each day, and it's about all we can do.
Mute.
Now I'm the one on mute. I was just saying thank you so much, Bruce. And Krista and Richard, I'll come to you quickly as we're ending out the panel. Is there anything that you'd like to add that providers could have done or did for you that was helpful?
Yeah, so I'll be real quick because I know that we're at time, but I wanted to say that I feel like I had a great team that worked well together. Some things that I think could have been, supplemental would be, let's talk more about what happens after. You described it well in your talk when you talked about, you're used to seeing all these caregivers going to appointments a couple times a week, and then it's over and you're like, now what? What do I do now? So let's talk more about that. Let's talk more about maybe some of the things you introduced early on that now I'm going to start experiencing, like lymphedema and, things like that. Let's talk about those again, have those conversations. So I think really just talking about the person as a whole. I know the surgeon's worried about, let's get the cancer out, but thinking about the person in a collective manner at all times, I think it should be at the forefront. But outside of those couple of things that I can think of real quickly, that's what I would suggest for caregivers or the care team.
Thank you. Richard?
I should probably mention I was at Wishart Hospital for 10 years in ER, and being a firefighter paramedic, I saw the importance of a thing called the placebo effect. You know, so when I gave patient care, I knew 30% of my behavior, how I acted towards that patient, eye contact, not necessarily words, but just showing the empathy, you know, through your eyes. And you can feel that stuff, especially at Wishart when you had to wait 12 to 14 hours to be seen for whatever reason. I found it interesting that there was a lot of nurses there that, because we were overwhelmed, short-staffed, that it played on their attitude and their behavior towards the patients. And so they were rude. So I saw the difference there. It was never judgmental. I don't care who you were waiting in that line. It's your turn now. I'm going to look at you and give you the attention and the proper care that you need. And I would get written up once a year for being a little bit longer with the patients than I should have been. But hey, keep on writing me up because you're going to get my service. And you know, I just want to take care of you. So that placebo effect, just being positive, you know, loving and caring, it really helps out. Whether you have cancer, you know, you're injured, you're on your deathbed. My mother always said, you know, treat people how you want to be treated. And I kind of live off that basic foundation, those words. That's pretty much it.
Thank you so much. I cannot say enough, both to Eukarya, Richard, Lisa, Bruce, and Krista. You know, talking about survivorship and really hearing from you guys is absolutely my favorite part. And I think it's how we can learn the most and also help support survivors. So I really, truly thank you for sharing your stories, being so vulnerable and frank, and helping inspire us to do better. So I want to thank you all again very much for being here today.
Thank you, everybody.
Thank you.
Take care of yourself.
Thank you all. So with that, we are going to transition to our award ceremony and our closing remarks. So I'm going to hand it to Katie Crawford.
Thanks, Mary. Hi, everyone. I'm Katie Crawford. I'm with the American Cancer Society, and I have the great honor of being the vice chair of the ICC board. It's now time to celebrate our extraordinary accomplishments of the ICC members and the cancer control advocates with this year's ICC award ceremony. While we can't physically give each recipient their award today, we're excited to celebrate their achievements. Before I begin, I want to note that each award winner will have just a few minutes for remarks. We do ask that you guys keep those brief. I also want to mention that this is a list of very accomplished individuals. In an effort to keep us on track and time, I have shortened some of the bios, so I apologize if I haven't hit all of the remarkable highlights of your professional careers. So our first award in the Cancer Control Championship Award category, which focuses on the accomplishments and commitments of Hoosiers over the past year. These candidates were nominated by the ICC membership and selected by the ICC Advisory Board. Cancer control champions must exhibit leadership in implementing the Indiana Cancer Control Plan through participation in ICC work groups, committees, and other cancer control efforts. This year's first cancer control champion is Dr. Catherine Head. Dr. Head is an associate professor in the Department of Communication Studies at Indiana University, Purdue University, Indianapolis, as well as affiliate faculty with the Fairbanks Center for Medical Ethics and an adjunct faculty in the Medical Humanities and Health Studies program. She currently serves as the chair of the advisory committee for the Indiana Immunization Coalition and is a member of the steering committee for the Health Communications Working Group at the American Public Association. Her research focuses on health and medical communication, and much of her scholarship has focused on how individuals communicate about, make sense of, and make decisions about vaccines, cancer preventions, and medical test results. I'd like to invite Dr. Katie Head to make a few remarks.
Thanks, Katie, and thank you so much for this honor. It's such a wonderful thing to be awarded. Like many people on this meeting, cancer is personal for me. And as a communication professor, I'm grateful to the many individuals in Indiana who work in cancer control and prevention, who have invited me to their table, who have taught me, who have mentored me, and allowed me to come in and try to see how we can use communication to help improve cancer care and prevention. You know, I want my work to make cancer prevention and cancer treatment easier and more effective, at least when it comes to what information we need to share and what communication strategies we can use depending on our different audiences. So I see a few of those people on this call, and I just want to thank people like Rivian, who have taught me a lot about doing community-based work. Lisa Hayes, who's taught me a lot about how to really listen and respond to patient needs to be able to design interventions. Monica Casting, who I work really closely with on a lot of HPV vaccination work. And I have to thank my mentor, Dr. Greg Zimmett, who I know many of you know. I think he's on vacation this week. I think he picked a good week for it with the snow. But thank you to all those people. This award is such a nice way to mark the work that I do, and it will encourage me to continue doing it. Thank you.
Thank you so much, Dr. Head. Our next champion is Dr. Ruth Stevens. Dr. Stevens has been with HealthLink since 2013 and has over 22 years of experience and expertise in clinical systems development, clinical management, and clinical and operation quality performance improvement. As the Chief Quality Officer for HealthLinks, a federally qualified health center in Northern Indiana, Dr. Stevens oversees the organization's quality directives as required by the federal government, including those related to cancer prevention and control. Providing education, awareness, and preventative screenings is particularly challenging for the marginalized population served by community health centers, who routinely face social determinants and other barriers to access. Over her 5-year tenure with HealthLink, Dr. Stevens has established a foundation of support for cancer prevention efforts that have led the organization to commit resources, resulting in a greater number of cancer screenings, targeted education and awareness efforts, and an organization-wide advocacy for cancer prevention. Please join me in welcoming Dr. Stevens.
Good afternoon. Today, I humbly accept this award. Thank you for selecting me. Thank you to HealthLink's quality and clinical staff, without whom this achievement would not have been possible. I'd like to dedicate this to Dr. Vicki Curry, who started me on this road as a high school senior by allowing me to do cancer research at Jefferson Medical School in Philadelphia. Thank you.
Thank you, Dr. Stevens. Next is Evelyn Hunter. Evelyn has been a social worker since 2007. She has worked with high-risk families, individuals with disabilities, and worked in private practice counseling. She has been an oncology social worker for the past 6 years. In addition, she has had a 16-year career as a paramedic in a mid-sized city. She finds that her experience in the medical field and in working with individuals with many different types of barriers helped prepare her work with the individuals who are diagnosed with cancer. Evelyn strives to find avenues to help meet many of her patients' needs. This includes community resourcing, helping patients to cope with distress through counseling, improving coping skills, or just to have someone to listen to. Evelyn, we'd love to hear from you.
Hi, I am really thankful for and honored to be given this award. And where I work and being supported from my coworkers and supervisors, I know that I could not have done the things that I've done in the past 6 years had it not been for mentors and people that, introduced me to others so that I would know more about social disparities within cancer and community outreach. And there's a lot of people within the ICC that, have mentored me and helped me, like Michelle Hoskins and Mindy Birch. And one of my couple of mentors in Louisville who work within the Baptist Health system, Shelley Nally. And I'm just thankful for everybody who's taught and mentored me. It's a great honor. Appreciate it.
Thank you so much, Evelyn. Thank you and congrats to all of this year's Cancer Control Champion Award winners. We really appreciate all that you do in our state. Next is our Outstanding Contributions Awards. Each year, one organization and one individual are chosen. Outstanding contribution awardees must dedicate their mission and lives to cancer prevention and control and have had major contributions to cancer control in the areas of primary prevention, early detection, treatment, quality of life, data, and/or advocacy. This year's award for Outstanding Contributions in Cancer Control Individual Award goes to Rivian Shed Steele. In her role as the Assistant Director of Operations for the IU Simon Comprehensive Cancer Center's Office of Community Outreach and Engagement, and as the Director of Cervical Cancer Free Indiana, Rivian has developed programs that enhance patient-provider communications and programs that improve cultural and linguistic competencies in delivering health-oriented services. She also develops systematic approaches to improve the coordination and utilization of behavioral and clinical research and program outcome evaluations. Rivian works with statewide community partners and supports activities that address racial and ethnic health disparities through community-based activities to promote health, lower cancer risks, and increase access to and utilization of preventative healthcare and treatment services. Rivian's programs enhance IUSCCC's efforts to expand overall outreach to the medically underserved, including minority groups and people with limited access to health information and services who are oftentimes located in rural areas. And this is just such a very small portion of all that Rivian has done, but I'd love to extend the floor to Rivian.
Thank you so very much, as I am overwhelmed with gratitude in accepting this prestigious Cancer Control Award. I'm honored to have my work and contributions to the community recognized in this special way by the Indiana Cancer Consortium. This accomplishment is nothing that I made alone. During the conference today, I've been humbled to be in the presence of the many individuals who have truly enhanced my efforts. Many thanks are directed to the individuals and community partners who supported my efforts in making community outreach much more than presenting health-related science to lay audiences. My special thanks are directed to those who supported my efforts in changing the mindsets of many from health-disparate populations who initially thought they couldn't afford to be sick and later discovered that community agencies, clinics, and hospitals could provide them with low to no cost cancer screenings and treatment. And most of all, my thanks to the IU Simon Comprehensive Cancer Center, including Drs. Vicki Champion and Greg Zimmett for their unending support while enhancing my overall efforts in putting evidence-based research into practice. Thank you to Pat Lair, Dr. Lair, who supported my statewide crusades that he backed by gentle reminders that Indiana was much larger than Marion County. To Dr. Virginia Kane, whose leadership and direction as chair of our Health Disparities Advisory Committee has been unprecedented. And last but not least, thank you to Dr. Kelvin Lee, our new Cancer Center director, who has extended continuous courtesies and unending support to me and the Department of Community Outreach and Engagement that will strengthen our efforts in making a tremendous impact in fighting cancer in the state of Indiana. If my work, dedication, and passion made individuals' lives healthier and better along the way, it's all been worthwhile, and I'd do it again in a heartbeat. Please know that this award always will hold a special place in my heart. Thank you again for this great honor.
Thank you so much, Rivian. It's so well deserved.
Thank you.
All right. This year's award for Outstanding Contributions in Cancer Control Organization award goes to Parkview Cancer Institute. Parkview believes complete cancer care extends far beyond just fighting cancer. That's why they're not just providing advanced treatments, they're providing personalized holistic care. When Parkview Cancer Center Institute opened its doors in 2018, they realized a new healthcare model, one that offers cancer experts who are subspecialized in each type of major cancer that they treat. This holistic healing environment with the innovative care model was built to be completely patient-centric, touching every aspect of the patient's journey from screening and prevention to diagnosis, staging, and treatment to survivorship and surveillance. Through it all, their focus on service excellence and their patient experience remains the heartbeat of what distinguishes Parkview Cancer Institute. Parkview Cancer Institute is also a certified member of the MD Anderson Cancer Network program, a program of MD Anderson Cancer Center. Today we have Andy Byram, Director of Tumor Site Teams for Oncology, to share a few remarks on behalf of Parkview.
Just want to say thank you to everyone, and really are honored to be able to receive this award on behalf of Parkview. Like you said, want to give a big thanks to the Parkview board for investing and giving us the resources that we need to be able to care for these patients and offer everything we do here. Dr. Sharma is our medical president. Without his leadership and vision, none of this would be possible. He is really the driving force behind so many of the programs that we have here. And then really last but not least, all the physicians and coworkers here at Parkview Cancer Institute who are caring for the patients every day and making sure that we deliver that excellent care to every single person that walks through our door. It's really special to be able to serve them and get to work with them. Just a big thanks to Mary and the ICC for today. Definitely after listening to all the presenters, makes me want to go out there and even do better. So I really give thanks to you guys for giving us the opportunity to get re-energized and refocused on what we do for our patients. Thank you.
Thank you so much, Andy. We appreciate your time today and all that Parkview does for your community. Okay, our next award is the David Caldwell Survivorship Award, which goes to a cancer survivor who is committed to reducing the burden of cancer in Indiana, exemplifies outstanding leadership, and empowers other cancer survivors and advocates. This year's David Caldwell Survivorship Award goes to Emily Smith. As a Central District Associate Wellness Director for the Downtown Indianapolis YMCA, one of Emily's focuses is on chronic disease programs and programming for active older adults. Her biggest source of joy comes from leading a cancer survivor program called Livestrong at the YMCA and the Little Red Door Cancer Agency, encouraging survivors to strengthen their body and mind through exercise and support networks. Like many others touched by cancer, she was diagnosed with chronic myeloid leukemia at age 17 and has devoted her life to helping others find confidence and strength after cancer. Please join me in welcoming Emily.
Thank you so much. It's a huge privilege to be able to listen to everybody's stories, and like Andrew just mentioned, it makes me want to do even more. So it's just been great to hear everything. Like you mentioned, I was diagnosed with leukemia when I was 17, and the timing of cancer really impacts how you respond to it, or how you're able to respond to it, and kind of where you saw your life going. So for me, I was ready to decide which college I was going to commit to and run there, and I was really active and really excited. And then this huge roadblock got in my way, and maybe I'm going to have to wait on that and kind of choose a different path. So everything worked out exactly how it was supposed to. I even met my husband because he came up and thanked me after I talked to a school after just about my cancer journey. And he was the only high school senior to come up and say, thank you for being vulnerable and sharing your story. So I met my best friend by, talking about my story. So I love to talk about, what I've been through, how my family supported me and my network. And Livestrong at the YMCA is truly, truly what I am passionate about. So I'm able to have this class at the YMCA, but also with our partnership with Little Red Door. And I'm so thankful for Little Red Door and the outreach that they do. So this program, it focuses on, building strength and confidence, but they get a sense of community, and the self-esteem that I have seen grown in our 12-week sessions together is just unlike anything I've seen before. And usually I hang on to a lot of the people and I'm like, come back to the Y and see me. I'm not going to let you go. If you need help, I am still here even after our 12 weeks. And so we're together through, people who are just finishing treatment and they're getting back to, redefining their identity and what exercise and movement means. But we've also had times where we've had people re-diagnosed. And so you have that support network already built into that program. And the best part about this program is that it's completely free. The YMCA does amazing work to make sure that this is a completely free program for cancer survivors. So it's a win-win, saying, you know, come in, let us love on you and help to redefine who you are and what cancer might mean in your life, you know, without, you know, making it all pretty and everything. We want to talk about things that are the not so good, but we also want to highlight the days that are good. So I'm just so thankful for this award, and continue to do some great work. And it's exciting to hear all the other work being done as well. So thank you.
Thank you, Emily. We appreciate all that you're doing. All right, our next award is the Indiana Cancer Prevention and Control Policy Champion Award. This award recognizes individuals who engage in reducing Indiana's cancer burden by advocating, supporting, or implementing policy or legislative changes. So this year's Indiana Cancer Prevention and Control Policy Champion Award goes to Brian Hannon. Brian is the Regional Director of Government Relations for the American Cancer Society's Cancer Action Network. Working with public officials at the local, state, and federal level, Brian directs policy campaigns to make cancer prevention, detection, and research a public policy priority. Previously, Brian led grassroots advocacy efforts in Indiana for ACS CAN, where he helped thousands of volunteer advocates connect with their elected officials on a variety of public health and cancer prevention policies. Please join me in welcoming Brian.
Well, thank you, Katie, and thanks to Mary and to Dr. Halverson and the whole ICC team for the work you do and for the recognition. I'm grateful for it. I'm humbled by it. That's in large part because any of my contributions are almost always done in partnership with so many of you. And I feel despite our contributions, there are still so many challenges ahead of us here in Indiana, from our high rates of smoking and obesity to our low rates of HPV vaccination and physical inactivity. There are just so many challenges for us yet to work on. And I guess, and the other thing I would say is those challenges, of course, do not fall equally across all populations. There are many Hoosiers that are suffering from those disproportionately. And so there's a lot of work to do. And I guess in my minute with you all, I would just encourage you to find ways you can continue to contribute to public health policy in Indiana. From my perspective, it is, the number one avenue for us to make large-scale population health improvements in Indiana, and it's desperately needed. And so we will continue to work with our elected officials on these issues, and I just encourage you to find ways that you can continue to contribute to that work in your community, at the State House, at the federal level. Advocacy is needed from those of you who are often on the front lines. So, thanks for your support and contributions, and thank you for the recognition. I appreciate it, and I look forward to working with you all moving forward.
Thank you, Brian. It's always a pleasure, and I rest a little easier knowing that you are fighting the good fight. All right, the last award that I'll be presenting today is the ICC Sustained Excellence Award. This newer award recognizes organizations that have long-standing contributions to the ICC and recent notable achievement. The ICC Sustained Excellence Award goes to the Hoosier Cancer Research Network. Hoosier Cancer Research Network, Inc., formerly known as Hoosier Oncology Group, is an independent nonprofit contract research organization that specializes in early phase, multi-center, investigator-initiated oncology clinical trials. HCRN studies are conducted through a nationwide network of more than 450 academic and community sites. HCRN's highly qualified team provides comprehensive study management, including budgeting, contracting, LOI submission, study design, regulatory and IND support, custom EDC development and validation, safety reporting, monitoring, including site management, correlative management, data management, and support for publication. Hoosier Cancer Research Network's vision and mission is to form unparalleled relationships between academic, community, pharmaceutical, and biotech collaborators with the goal of advancing cancer research, education, and patient advocacy. While HCRN could not be here today, their executive director, Cindy Burkhart, has sent a video that we will play now.
Thank you to the Indiana Cancer Consortium for choosing Hoosier Cancer Research Network as this year's recipient of the Sustained Excellence Award. As a nonprofit organization, HCRN serves investigators and clinical research sites in the development and conduct of clinical trials. As HCRN's representative, I was honored to have a seat at the table for the very first statewide cancer control plan, working alongside Dr. Steve Williams of the IU Cancer Center, as well as many other outstanding individuals. Over the years, the ICC has had significant accomplishments in the areas of patient advocacy and initiatives related to ensuring access to clinical trials statewide. I served on the ICC's Patient Advocacy Committee and appreciated the group's commitment to involving patient advocates in discussion and decision-making. In addition, the Treatment Access and Utilization Committee, on which I also served, recognized clinical trials as a key aspect of comprehensive cancer treatment. These discussions directly led to the creation and signing of HB 1382, the bill that ensured patients were not denied insurance coverage for participation in clinical trials. I am proud of all the hard work and effort that led to this significant accomplishment. We are grateful that the ICC continues to recognize the important role that clinical trials serve in improving the lives of cancer patients in Indiana. On behalf of HCRN, thank you again for this recognition.
Wonderful.
Thanks so much. Congratulations to all of our award winners this year, and thank you to the membership who nominated them for all these incredible candidates. Mary?
Awesome. Thanks so much, Katie. So we also are presenting our award for organizations that have completed our Employer Gold Standard, or our Employer Gold Standard certified. So these organizations have committed to establishing the workplace as a key area to promote wellness initiatives and evidence-based cancer screenings to all employees. So this is a free recognition program that emphasizes access and education to cervical, colorectal, and breast cancer screenings. So all organizations are eligible regardless of size or industry. So for anyone that's wanting to participate, please visit our website, indianacancer.org, on our EGS page. And we also do have a mini grant opportunity that's supporting this initiative as well. So at this time, I'd like to congratulate Indiana University for being our most recent Employer Gold Standard certified organization. Indiana University's mission is to provide broad access to undergraduate and graduate education for students throughout Indiana, states, and the world, as well as outstanding academic and cultural programs and student services. IU has 9 campuses across the state and over 21,000 faculty and staff university-wide. So I would, in addition to the employer's pay, university-sponsored benefit plans are a significant part of IU's total compensation package. And these plans help sustain and build the academic and strength of staff and the vitality essential for the university to carry out its mission. So Indiana University is committed to providing benefits that help protect employees' health and welfare and strengthen their financial well-being and provide paid time away from work. So we want to thank them for taking on this initiative and with the health and wellness of their employees in mind. And with that, I would like to invite Samantha on behalf of IU.
Thanks so much, Mary. On behalf of Indiana University, I'm really honored to accept this ICC Employer Gold Standard Award as a leader in employee wellness. This recognition really would not have been possible without the collaboration and efforts of many individuals and departments across our university. As Mary said, here at IU, we really value our employees and we're committed to helping them live their best lives, both at work and at home. And we want them to feel supported and cared for because we know our people are their best when they're happy and healthy. So the topic of cancer actually was quite a journey for us. Recently, We completed the Centers of Disease Control Worksite Health Scorecard as an assessment tool, which is common what we do before we begin a new strategic planning phase. And cancer was one of the top areas of opportunity for us, and we knew we wanted to prioritize that. Shortly after getting an email from ISDH on asking if we wanted to go on this adventure with them, I since then cannot thank ICC and ISDH enough for their encouragement, expert guidance, and feedback. They really make this process so easy. So I would highly encourage other employers to do that. I just feel so fortunate to have organizations and resources like these available to support the employers in Indiana. So IU has many internal partnerships providing cutting edge research, experts in the medical field, which we're able to tap into to provide some expert educational sessions, and people that are just passionate about wellness and helping others. So I do want to recognize the IU Simon Comprehensive Cancer Center, the IU School of Medicine, our two schools of public health, and our IU Human Resources, who've really been collaborating with us through this process. And I know we've just started focusing our efforts more this year, but really ICC and ISDH are providing really great feedback, and we really look forward to learning from other employers across the state. So finally, we know screenings are imperative for the early detection of cancer. And we also know that for many, that preventive medical care, including cancer screening, was put on hold due to the COVID-19 pandemic. So we're just honored to join the fight to influence these statistics. And we're committed to sharing the important message that screenings do save lives. So thank you again for your support, Mary, and thank you again for this honor.
Thank you so much, Samantha. And I would just like to echo, it's been a pleasure working with you guys on this initiative. And I just want to reiterate that it's very prescriptive, and we have a whole team to support any organization that would like to go through this process as well. So thank you again, and congratulations. Congratulations to all of our award winners. I do apologize. I know we are a bit over today, but I am about to say our closing remarks. So very excited. So thank you all for taking the time out of your busy day to attend this year's ICC annual meeting virtually. Hopefully we can be in person very soon. Thank you to our speakers for sharing your expertise with us. We really have had an incredible time today, and I know, like many others, I am very re-energized in our work that we do. And I hope you all are inspired to continue your work as well. We hope that you will utilize the Indiana Cancer Control Plan and resources as a guide for targeting limited resources to areas of greatest need and potential impact. Again, as I mentioned earlier, our mini grant opportunity for our Employer Gold Standard is on our website, and I do encourage you all to seek that out. We always welcome your input on how to make things in these meetings even better. So please make sure to complete the evaluation survey that is in the chat. That is also needed to be completed if you would like to receive continuing education credits for today's meeting. Again, I just want to thank you for joining us so much today. It's been a pleasure, and I would like to conclude the meeting. Thank you.